Thank you for joining the Finance Committee. Today is Tuesday, February 11th. Thank you for joining us on this potentially snowy day. I'm Senator Pam Vidal, Chair of the committee, and who will be here shortly, my Vice Chair, is Senator Hayes, and I'm going to read the order of the bills. I just will remind everyone, please, the sponsor has as much time as you need. All the witnesses have 2 minutes. Please honor that. We have 94 witnesses today. We're going to start with Senator Henson, Senate Bill 508. Senator, if you'd like to come and bring your councilwoman from Prince George's to the table. And then we have Senate Bill 492, 495, 465, 539, 486, 448, 447, 458, 21, and 538. The order is subject to change depending on the availability of the committee, who may be in other committees testifying. So thank you for joining us, and Senator Henson, you can begin when you're ready.
Thank you, Madam Chair and distinguished members of the Finance Committee. For the record, I'm Shanika Henson, Senator for District 30. I did have signed up to testify as well Councilwoman Crystal Orianda and then also a Ms. Tasha Scott. Madam Chair, I believe both of those witnesses will be unavailable to appear due to the weather. So if it pleases the committee, I'll proceed forward with just my testimony.
Absolutely, Senator.
Thank you. Again, I'm Shanika Henson, District 30. I'm coming to you on a bill, Senate Bill 508, Maryland Medical Assistance Program and Health Insurance, required coverage for aesthetic services and restorative care for victims of domestic violence, known as the Healing Our Scars Act. It may or may not be known to my colleagues. I spent the first 3 years as a practicing attorney representing survivors of domestic violence. I worked with our domestic violence service provider here in Anne Arundel County, representing those survivors in peace and protective order hearings and also custody proceedings. During that work, you realize that domestic violence can often be a very brutal and a very vicious experience that leaves many bodily injuries on the survivors. Our health insurance coverage plans, there are determinations that they make on what services to provide coverage for, and one of those services that's often left out of that coverage is what we might deem cosmetic in nature. And with that service, there are often wounds, injuries, scars that are the reminders and the vestiges of someone surviving domestic violence. Well, what this bill would do is it would require our insurance carriers to cover those services that would be deemed cosmetic in nature, but for the result of those injuries being from domestic violence. So it is a simple bill that would have an application that would help bring healing to many people who survived their domestic violence, but are now looking to move forward with their life and have those final vestiges of those injuries repaired through what might otherwise be deemed cosmetic surgery procedures. I am submitting it for the committee's consideration, and with that, I'd ask for a favorable report on Senate Bill 508.
Well, thank you for your testimony. Short and very well done. Thank you, Madam. Do I have any questions from the committee? Senator Mounts?
Very quick, how do you define domestic violence? Is it a person that's been, I'll let you answer that question.
I appreciate the question, Senator, and I think it's essential to the bill. Under the bill, it defines domestic violence as someone who would seek relief under Family Law Article 4-501, and 4-501 does have a specific definition for domestic violence. That's our Peace and Protective Order statute, so it kind of mirrors all those different eligibility for relief. If you're eligible for relief under that statute, you'd be considered a victim of domestic violence.
Okay, thank you.
Thank you, sir.
Good question, Senator. Any other questions from the committee? Thank you very much.
Thank you, Madam Chair. Thank you.
Ends the hearing for Senate Bill 508. Next, we have Senate Bill 492, Senator McKay. Let's see who came from Western Maryland to testify today, Senator McKay. You have David Risch, Caitlin McDonough, Mary Backley, Dr. Mulaney Bell, Robin Elliott. And then we'll have two virtual members of your panel before we go for questions.
Yes, ma'am.
So, Senator, you can start when you're ready.
Can I stand up? Thank you. Thank you, Madam Chair. Thank you for this opportunity. I see that there is another eye candy in the Senate sitting here with the good senator over there. We have a competing joke about who's the best looking gentleman in the Maryland General Assembly, and it's kind of like looking in a mirror. So if I get a little distracted, it's going to be that. It's going to be that. So it's one of those circus mirrors that one is thinner and one is more heavier, but it's the same image.
Okay, we got his vote.
Okay.
Move favor.
Thank you, Madam Chair. Thank you to the committee for letting me have the opportunity to bring Senate Bill 462 to you today. This bill is a next step in the overall commitment of increasing access to dental care for all Marylanders. Now, in 2022, Delegate Bonnie Cullison and I sponsored House Bill 6. This was groundbreaking and provided dental coverage for almost 800,000 adults enrolled in Medicare or Medicaid. On the Senate side, Senate Bill 150 was sponsored by Senator Malcolm Augustine and Senator Guy Gazzone. Now, since that bill's implementation in 2026, there's about 200,000 adults who have obtained dental services using their Medicaid coverage. Some people have not seen a dentist for decades because of their lack of coverage. Now they have access by preventative services such as cleanings, overall restorative services such as fillings, and the services will keep them healthier overall and keep them out of their emergency rooms. Now, we indeed need to turn our attention to ensuring that we have enough dental providers to serve our communities. Dental hygienists are a critical part of our dental workforce, yet I've heard reports that it's extremely difficult to filling a dentist hygienist position in my district. As Monday, I went and got my teeth cleaned, and they said it'll be just a moment because we've got a shortage and somebody was sick and could not come in. We're having a hard time with dental hygienists. So I expect that you'll hear the same reports in your district as well. Our Maryland experience with dental hygienists reflects the national trend. According to the Health Policy Institute, 92% of dental practices have reported that they have been extremely or very challenged when recruiting dental hygienists. Senate Bill 492 establishes a commission to study the dental hygienist shortage. I did not craft this bill from scratch. We looked at the work undertaken by Chair Beidel with Senate Bill 440 in 2022, which established a commission to study healthcare workforce crisis in Maryland. As a result of the commission's work, Maryland has made progress, particularly in nursing and innovative programs. For example, the commission recommended to lead to Senator Lamb's Senate Bill 718 from last year and to create a wraparound services for nursing students in community colleges as a pathway to nursing program. Now, under Senate Bill 462, the commission includes educators, community colleges, the University of Maryland, Baltimore, dental hygienists, dentists, and public health policy makers. The commission is charged with developing recommendations in key areas, the recruitment and retention of dental hygienists across different regions of Maryland, how we can support our dental hygiene education programs to meet the growing need for dental hygienists, and how we can support dental assistants in the community of healthcare workers to ensure dental hygienist programs will and can be successful. I'd like to thank this opportunity for the committee for working a long history of supporting dental access in Maryland. I ask for your favorable vote for Senate Bill 362, and as a self-proclaimed Senator Smiles, formerly known as the dental delegate, I look forward to working with you as a committee to see this passage. Thank you.
Thank you, Senator. Who would like to go next?
Good afternoon, Chair Beidel, distinguished members of the committee. My name is Mary Backley. I am the CEO of the Maryland Dental Action Coalition, a statewide network of individuals and organizations working collectively to improve the oral health of all Marylanders through prevention, education, advocacy, and access to care. I appreciate the opportunity here to express our strong support for Senate Bill 492. I'd also like to express my sincere and deep appreciation to the bill's sponsors, Senator McKay as well as his colleagues, Senator Augustine, Senator Guzzoni, and Delegate Cullison, for their leadership on legislation that did establish the Medicaid adult dental coverage, and also to thank this committee for its strong support of that legislation. Launched a little over 2 years ago, utilization of this program has been extremely positive, with over 30% of the Medicaid adult community having received important dental care. This will have a profound impact on their overall health as well as their quality of life. But as more people seek dental services, the need for more dentists and dental hygienists increases. According to a recent report issued by the Health Policy Institute of the American Dental Association, over 90% of dental practices nationwide reported it to be extremely or very challenging to recruit dental hygienists, and that has had a direct impact on their capacity to treat patients. Maryland is facing this recruiting challenge also. Since the COVID pandemic, we saw a significant departure of dental hygienists from the profession, producing a shortage and reducing access to care across Maryland. The shortage of dental hygienists is uniquely felt at community health centers and dental clinics at local health departments that provide important care to vulnerable residents. By assessing and studying the dental hygiene shortage in Maryland and the impact on oral health in rural, suburban, urban communities, the Commission can develop an effective roadmap to improve care. Thank you for the opportunity.
Sure. Good afternoon, and thank you for your time. My name is David Reish, and I'm here on behalf of the Community Health Worker Empowerment Coalition of Maryland. We're a coalition founded by the Public Justice Center. This CHW-led coalition advocates to expand access to CHWs to address health disparities in Maryland's low-income communities, as well as working to address other inequities in the field. So we work to give CHWs a voice in policies that impact them, so please take note of the written testimony our coalition has also submitted. We're here in strong support of SB 492, which would create a commission to study the dental hygienist shortage. It's critical for people to have access to oral health care. Dental issues don't just impact the mouth. The body's immune system can impact your entire body in response to dental issues. They're linked to cardiovascular disease, cancer, dementia, and other serious issues. This proposed commission will develop ways to connect CHWs to training that'll help keep their patients engaged in dental care and support both patients and dentists. CHWs are already practicing in dental settings. They go beyond the dentist office to address social determinants of health and keep patients healthy and out of the emergency room. A dentist might recommend consuming less junk food, but it's up to the CHW to make sure their patient is enrolled in safety net services and can actually access and afford healthier food. A dentist can offer treatment at their practice, but it's CHWs that make sure patients have transportation to get there. CHWs bridge the divide between patients and providers and are especially effective at reaching hard-to-reach patients who are not well served by our health system. Dental care is one of the most unmet health needs, with 1 in 3 adults suffering from untreated tooth decay. This is only exacerbated by the acute shortage of qualified dental personnel. The care CHWs provide will help us fill gaps in our dental workforce and address this critical shortage. Community-based care keeps people out of the emergency room and saves the health system money. So we therefore urge you to support SB 492 and support community health workers in the dental workforce so that every Marylander can achieve their highest level of health. Thank you.
Thank you, David. Dr. Melanie Bell?
Good afternoon, Madam Chair and members of the Senate Finance Committee. I'm Dr. Melanie Bell, co-founder of Beyond Nursing and LLC and board member for the Maryland Dental Action Coalition. MDAC strongly supports Senate Bill 492 as its pathway to professional excellence. As a registered nurse who started her career as a tech, obtaining an associate degree, bachelor's, master's, and now doctorate, I understand the importance of providing a pathway to achieving mid-level and terminal degrees in dentistry, just as we do for nursing. Creating a pathway for dental assistants and community health workers will greatly improve the trajectory to becoming dental hygienists and beyond. The pathway will increase the number of learned professionals, increase access to care for our beloved citizens, and decrease burnout within the population. According to the American Dental Hygienists Association, there is a reported 22% burnout rate within the profession, and we can't afford to lose valuable career professionals. Maryland has greatly improved dental access via additional insurance coverage with Medicaid. I had the opportunity to testify on that bill. Thus, the prevention of oral disease is at the forefront, and the demand for dental hygienists is growing. Increasing access to care improves prevention, and routine care decreases the prevalence of a new onset of oral diseases, which sometimes prevents necessary life-saving surgeries. Lastly, it is imperative that dental hygienists maintain their professional designation titles as they've achieved a profound level of expertise by mastering their education, training, and licensure requirements. Again, I strongly support Senator McKay in his vow to improve oral access to care via education, increasing the number of dental hygienists, forging the path to excellence, and leading Marylanders to a healthier tomorrow. Thank you.
Thank you. I guess, Caitlin?
Thank you, Madam Chair. Caitlin McDonough here on behalf of the Maryland Dental Hygienists Association in strong support of Senate Bill 492. I'll start by thanking Senator McKay and the committee for his work on these issues, and also for recognizing dental hygienists for their kind of unique role they play in the oral health care system here in Maryland as preventative providers. I know often can be a hesitancy among the legislature to create commissions or work groups or kind of other study nature legislation. But we do within the association feel like this is an issue where we need different stakeholders to weigh in. It's a multifaceted issue, and something, honestly, we would feel uncomfortable putting forward recommendations or legislation from our association without really looking at the issues. And we also appreciate the bill has a lot of flexibility about what types of issues could be looked at, and some of which may result in recommendations around legislation, others which may be things the department or the administration can do, like around reimbursement rates and whether we could directly bill reimbursement when we're mobile or going out into public health settings, barriers to education, both financially and otherwise, looking at scope of practice, looking at our role in the oral health system vis-a-vis dentists, dental assistants, and other providers along that chain. As Senator McKay said, we are unique in this role. We want to be able to serve our patients and be as effective as we can in the state, particularly in underserved areas and underserved populations. And we think this bill is an important first step and look forward to participating both as hygienists, as educators in the dental hygiene field, and however other way we can be helpful. And I'll just take my last 10 seconds to thank Mary and MDAC for kind of spearheading this effort and bringing all the different stakeholders together. We think this could be a really important bill for us and for oral health generally. So thank you.
Good afternoon, Madam Chair, members of the committee. Robin Elliott. I'm here today representing 3 organizations: the Maryland Dental Action Coalition, a group of federally qualified health centers called Maryland Community Health System, and then the school-based health centers, very much in support of this legislation. Just wanted to lift up really the importance of having a multifaceted convening of all the different stakeholders. I know it sounds like a lot of work, but I wanted to lift up that this group does not have to start from scratch. There are some resources detailed in testimony, but first, the Virginia Health Department has a wonderful yearly report on dental hygienist shortage, and we could use that as a potential template for work in Maryland. Second is that the American Dental Association has a division called the Health Policy Institute. They've done some incredible work in analyzing the data around shortages of dental hygienists nationally that we can adapt for looking at the issue in Maryland. And third, I just want to give a shout out to our colleagues in the dental hygiene education space. There is a Maryland Coalition for Allied Dental Education that includes all the different community college programs and the University of Maryland, Baltimore. They are very active. They're conducting surveys. They are kind of coalescing with their dental hygiene education colleagues to come up with their own recommendations. So this would really integrate their work into our larger public health discussions. And with that, I ask for a favorable report. Thank you.
Thank you, Robin. And now we'll have the 2 virtual members of the panel. We'll start with Betty Peebles. You have to unmute, Betty, unmute and start over. You need to unmute. There's a little microphone that you need to click on so you unmute. Just looking for help. You see the little microphone? There you go. Thank you.
Thank you very much. Thank you. Thanks, everyone. Thank each of you for your commitment to oral health by advocating for this wonderful legislation this session to address the severe shortage of dental hygienists. You continue to keep your promise you all made for Del Monte drivers so many years ago. My name is Betty Peebles. I'm a hygienist and the owner of the largest dental staffing and travel company in the country. We operate in 23 states, including Maryland. Currently, I'm the board chairman of the JCB Foundation, which has studied this issue in depth, and we have a plan we hope will make change. In the recent census of the United States, the Department of Labor found that the U.S. will require 15,400 new hygienists each year for 10 years to fill the current demand. It's clear that there's a structural workforce shortage across the country, and here are a few reasons. Most hygienists attend community college programs. These are approximately 325 of these programs and across the country, and each program graduates 20 or so students annually. That means we're short between 6,000 and 8,000 hygienists each year. We need more programs and we need larger class sizes. These newer programs should be considered to be placed in our rural areas. Number two, we lack diversity. Over 89% of dental hygienists are white and 95% are women. As a recruiter, I can tell you that if we only recruit from one small segment of our communities, we will fail. We need to reach out to all new communities and find diversity. Number three, we have a very high attrition rate, both in the programs themselves prior to graduation and in the practicing group. This significant is higher than other professions. The reason major healthcare program, and we are anxious to help and support your efforts. Thank you for having me.
Thank you, Betty. Next we have Katie Batani.
Yes, thank you to Chair Beidel, Vice Chair Hayes, Senator McKay, and committee members for allowing me to testify today in strong support of Senate Bill 492. My name is Katie Batani. I've been a dental hygienist in Maryland for 23 years. I've worked in both private dental offices and safety net settings, particularly for the Harford County Health Department in its dental clinics and school-based dental programs. I've seen firsthand the impact of oral diseases and oral pain on the quality of life of adults, pregnant women, and children. Fortunately, I've also seen the impact that dental hygienists can make as licensed preventive oral health specialists on improving the oral health of the public in both traditional dental settings and in non-traditional settings like schools, WIC centers, and prenatal and pediatric medical clinics. The dental hygiene workforce shortage in Maryland is being felt in both private and public health settings. In public health settings, recruiting dental hygienists has always been a challenge, and it is even more so now. The commission is needed to better understand where hygienists are working and why, and to develop recruitment and retention strategies for different types of practice settings in different areas of the state. I'd also like to remind the committee that as of a few years ago, dental hygienists can now practice in several non-traditional settings like nursing homes, assisted living programs, and medical offices in partnership with dentists. If we want to fully realize this incredible opportunity for dental hygienists to bring care to where people are, we need more dental hygienists in this state, not less. We've made some great strides in our state, but when it comes to the Medicaid population, only 1 in 3 dentists actively participates in the program. In 2023, only 30% of young children birthed through age 3 saw a dentist, and only 1 in 4 pregnant women enrolled in Medicaid had a dental visit. Dental hygienists can help improve these numbers in a variety of ways for which I'm confident the commission will identify. I ask for a favorable report to establish a 2-year commission focused on the dental hygiene workforce in Maryland. Thank you.
Thank you, Katie. So we have a few questions for the panel. It's a big panel. Senator Guile?
Thank you, Madam Chair. Thank you, Senator, for this bill. I have a question for Robin. Robin, how can the dental hygienist shortage be lifted up in the same way that we've lifted up the nursing shortage?
So that is a great question, and this bill is modeled after the work that Maryland has done on the nursing shortage. There are a lot of parallels. You can be a nurse or a dental hygienist with a 2-year degree, or you can get a 4-year degree. Educators in dental hygiene programs are hard to get because they're not paid enough, very similar to what we find in nursing. And as Dr. Bell, who is an expert who is a nurse, highlighted, there's a very clear pathway for people to become nurses and to continue to become APRNs. This bill is contemplating, can we take community health workers, dental assistants, if they want to continue on, support them into entering dental hygiene programs and being able to stay in those programs and be successful. I think Ms. Peebles highlighted there's a very high attrition rate from community college programs, very similar to nursing. So we can really look at what we've done for nursing and are still doing, not that we're totally done, but it's a great model for how we approach dental hygiene.
Great, thank you. Thank you, Madam Chair.
Thank you, Senator. And Senator Ellis?
Thank you, Madam Chair. And I just want to thank Dr. Bell for coming up. She's one of my constituents in Charles County. It's a long way, so good to see you.
My pleasure.
And going through the bill, commission, the composition of the commission is really a great lineup of individuals. And I just, as a background to my suggestion, ask you, Senator McKay, what you think about this. I'm a member of the Apprenticeship 2030 Commission, and so we've, for the last 2 years, done a lot of work in apprenticeships and how we can really increase so many professionals in our state. And I noticed there is no one from like Maryland Department of Labor, because Maryland Department of Labor has a Maryland Apprenticeship and Training Division. And would you object to us adding the apprenticeships folks on this? Because that's a possible way to maybe get more dental hygienists through the apprenticeship programs we have in Maryland and that we're standing up. Just want to add that the governor put a bill in, taking a lot of recommendations we have from the Apprenticeship Commission to really increase apprenticeships in Maryland. So do you think, would you object to us putting the apprenticeship folks in labor on this commission for?
Well, Senator, thank you for the question. Well, I have presented the bill. It is now the committee's will, and I think that'd be a great addition to it. So we'd be up to discussing that. But yes, sir, I believe it would be fine.
Okay, great. Yeah.
But there again, it's the will of you all.
Okay.
I'm just the eye candy.
Okay. I don't know how I respond to that, so I won't. Thank you, Madam Chair.
Thank you, Senator.
That's why I answer it that way.
I do not see any other questions for this panel. Thank you, Senator. And we're going to go on to one more favorable with amendment, Deborah Carty. And then we'll have 2 more virtuals.
Thank you, esteemed Chair Beidel. And thank you also to the members of the Senate Finance Committee. My name is Deborah Carty. I'm a registered dental hygienist. I'm a member of the Maryland State Board of Dental Examiners, and I'm here to represent the board, to speak on behalf of the board. The Maryland State Board of Dental Examiners respectfully supports Senate Bill 492. We offer an amendment. The board believes that the commission should include a dental hygienist member on the dental board, since the board's dental hygienist members possess firsthand knowledge and experience in the field and related dental hygiene issues and obstacles that arose during COVID-19 pandemic. Therefore, the board offers the following amendment. On page 2, in line 25, strike the word "and." In line 26, strike the period, add a semicolon, and add parentheses, Roman numeral 7, parentheses, one dental hygienist representative from the Maryland Dental Board. I respectfully urge the committee to carefully consider this amendment and return a favorable report, and thank you for the opportunity to testify.
Thank you, Deborah. Is that amendment request in writing by chance?
Yes, it is.
Thank you very
We've
much.
submitted it.
Do I have any questions for Deborah? No. Thank you very much for your testimony.
Thank you.
Next, we have a virtual witness favor with amendment, Mr. Charles Doring. I think it's Dr. Doring, isn't it?
Yes, thank you. Thank you. It is Charles Doring. I'm a general dentist in Rockville, Maryland. The weather is not holding me up. It's a bad cold for someone who used to drive Zambonis. But I want to thank Senator McKay and the Maryland State Dental Association and I submitted written testimony with including amendments here for Senate Bill 492. And listening to the previous testimony, I will reiterate the American Dental Association has some great data from its Health Policy Institute, and I suggest the workforce task group work on that as well. I also listened to some testimony regarding community health workers. The American Dental Association has a program called Community Dental Health Care Coordinators. These are like social workers that help reduce barriers, transportation, language, for example, so people could come in. And the way the bill is written, unless we include auxiliary and other dental workers, we're really just focused on dental hygiene, which is a fantastic team member. I have 3 full-time hygienists in my office, and they do fantastic work. But the team member that I'm really having a hard time filling is the dental assistants. Those are the ones that really take the strain off the stress for the dental hygienist. They're in charge of the infection control generally in the office, and they do the assistance for the doctors as well. So there's definitely a shortage. And the ADA Health Policy Institute says we've had some slight recovery on dental hygiene. We have 7 dental hygiene schools in the state, and talking about one on the Eastern Shore in the early planning stages. But I do want to reiterate that I do think we want a little broader picture, look at adding dental auxiliaries into the bill and ask for a favorable report with amendments. So thank you.
Thank you, Dr. Doring. Do I have any questions for this witness? I see no questions. Thank you for your suggestion. And our final witness is Matthew Rosetto with the American Dental Association. Matthew.
Thank you, Madam Chair. Good afternoon, everyone, and thank you very much for this opportunity to testify. Thank you to Senator McKay for the invitation for the ADA to provide informational testimony on Senate Bill 492. This is an impressive coalition that has already been put in place in support of this bill, and many of them have already covered some of the testimony that we submitted in writing. And so I will just highlight a couple of key points here for the committee. The first is you all well know that you are not the only state in this particular predicament. Your colleagues all across the country are looking at what levers they can push and pull, and frankly getting creative in solutions to increasing the number of hygienists available in the workforce. It's already been well noted that recruitment of dental hygienists and assistants both is a challenge. The ADA Health Policy Institute actually does quarterly polling on this. This is both from an economic and actual hiring standpoint. And so every quarter we have updated numbers on dentist confidence in their ability to hire, how difficult it is, and a variety of other things. And as again has been mentioned, I would encourage this commission, should it be established, to work with HPI, as there is a ton of state level data available. I'll finish by talking about 3 new policies the ADA House of Delegates adopted at its House meeting this past fall. These are a couple of potential ideas for states to consider. The first is one that the ADA directed toward the Commission on Dental Accreditation, asking them to adjust the instructor to student ratio in classrooms. We believe that increasing class sizes could help. There is additional policy on dental students and residents functioning as hygienists. And finally, potential policy to consider on internationally trained dentists functioning as hygienists, obviously with education and guidelines. And with that, thank you, and I'll stand for questions if necessary.
Thank you, Matthew. Any questions for this witness? Seeing no questions, thank you very much. That ends the testimony for Senate Bill 492. Thank you. Next, we're going to have Senate Bill 495, Senator Ellis. You're going to bring up Attorney General Anthony Brown and Karen Valentine from the Consumer Protection Division.
Do you want me to present? Or? Yeah. Mm-hmm.
Good afternoon, Chair Bottom, members of the esteemed Finance Committee. I'm Senator Arthur Ellis, representing District 28, Charles County, Maryland. We're all aware of the devastating effects the opioid crisis has had on and continues to have on Maryland. According to a 2023 Lancet report, opioids were responsible for almost 16 deaths per 100,000 people across the United States in 2019. And more than 100,000 people die every year globally from opioid overdoses. So today I'm eager to introduce Senate Bill 495, Opioid Restitution Fund, authorizes uses, which will improve the ability of the Opioid Enforcement Unit in the Attorney General's office to use funds recovered from these drug dealers to investigate them more and to get more resources to shut them down and prevent the large number of folks who have access to these dangerous drugs. The opioid crisis devastates communities and states across the nation as pharmaceutical companies and providers deceptively overprescribe opioids and mislead thousands of consumers. In a 2024 press release from the Attorney General's office, it's noted that the devastating impact of opioids and the importance of the Opioid Enforcement Unit in securing settlements that have allowed programs in Maryland to provide critical services to those impacted by the crisis. Maryland participated as part of a broader collaborative effort with other states who also received settlements from companies and prescribers involved in the crisis. And that's really big to know that our Attorney General gone after these individuals and won. Current legislation for the settlement funds already provides for certain authorized uses that ensures funding goes directly to support constituents and communities harmed by the opioid crisis. Under this bill, that will not change. Funds will continue to go to support those groups. Funding supports programs that provide preventive care and treatment for substance use disorder, for example. This bill would support this amazing work by providing resources to the Opioid Enforcement Unit to continue investigating and recovering additional funds that can continue to support these critical programs that support so many Maryland residents. What the Attorney General wants to do, we want to do with this bill, is the opposite of what's happening in Washington, where funds are being pulled out of enforcement units so that we cannot hold these bad actors responsible. Maryland is going the opposite direction, trying to beef up the funds and the opportunities to investigate and to hold these individuals responsible who flood our communities throughout the nation with opioids. Just want to say that imagine if we have a very robust enforcement unit here in Maryland, where we hold these people responsible, we shut them down if we can, we get a lot of money out of them. Imagine all the fewer addicts we'll have that we have to really support in Maryland. I believe making our enforcement unit stronger will lessen the impact on our communities. Therefore, I fully support Senate Bill 495 and ask for a favorable report from this committee. Thank you, Madam Chair and Committee.
Senator Attorney General Brown, please.
Thank you, Madam Chair. Members of the committee, I want to thank Senator Ellis for sponsoring the bill, and thank you for the opportunity to testify today. I come before you with a really simple but urgent request. Fund the Opioid Enforcement Unit within the Office of the Attorney General using the very funds that that unit has recovered on behalf of the state. Without this funding, our ability to hold opioid manufacturers, distributors, and other bad actors accountable cannot be assured. Maryland has secured to date already $670 million in opioid-related settlements. Over $180 million has already been paid, including more than $78 million in discretionary funds for the state. This work has been done entirely by OAG attorneys and investigators, not private law firms charging exorbitant contingency fees. Other states routinely pay outside counsel 24% or more, costing them millions in diverting funds from opioid remediation. We do it in-house. Maryland has taken a much more responsible approach. Now, despite our successes, the Opioid Enforcement Unit receives no direct funding from the Opioid Restitution Fund. This is an unsustainable model. To continue our work, we need $1.5 million annually. Now, the governor has put that in the budget for fiscal year 26, so we're not asking you for that money. What we're asking for is an amendment to the Opioid Restitution Fund, which already includes administrative costs as a permissible expense, and to clarify that that shall fund the Opioid Enforcement Unit in the Office of the Attorney General. In fact, we negotiate an additional $12 million, $13.4 million, 12 has already been received, for the costs of enforcement, and that goes into the Opioid Restitution Fund. It funds 5 assistant attorney generals, an investigator, a shared administrative assistant, plus litigation investigative expenses. I am not, if I may, Madam Chair, I am not aware of any inspection program in the state of Maryland, any compliance program in the state of Maryland, any enforcement program in the state of Maryland that recovers money for the state of Maryland and is not funded by the fund in which it recovers money. So we're asking to bring us in line with every other enforcement unit. Without this funding, we run the risk that we're not going to be able to continue our enforcement activities. This would reduce future recoveries and limit resources. So without further testimony, I do not have written testimony on this bill. I want to thank the committee and urge a favorable report on Senate Bill 495.
Thank you, Attorney General. And Karen.
Madam Chair, I should mention, I apologize. We have been speaking with the advocates. Who are the advocates? Those are the nonprofits around the state that advocate for the proper deployment of these funds, the nonprofits that are involved in treatment and other abatement programs. We've been in conversations with them, and we think that together we have a clarifying, favorable amendment for the bill to make sure that as you look at the language in the bill, it says, Opioid Enforcement Unit gets funds from the Opioid Restitution Fund. Kind of want to further clarify it that the funds within the Opioid Restitution Fund are those that I previously mentioned, that $13 million that are designed to cover the costs of the litigation. I don't need $13.4 million up front. I just need it sequestered, so about $1.5 million a year I'll be able to draw from that fund during a normal appropriation process. And we're working with the advocates. I don't want to represent that they support the bill as filed, but we're working towards an amendment that will strengthen this bill. Thank you, Madam
Mr.
Chair.
Attorney General, you're going to put that in writing to us?
Absolutely.
Thank you. Karen Valentine.
Good afternoon. My name is Karen Valentine. I am a deputy chief in the Consumer Protection Division of the Attorney General's Office. I oversee our opioids enforcement unit. I want to start by thanking the chair and the committee for providing me this opportunity to testify in support of Senate Bill 495. Senate Bill 495 amends Section 7-331 of the State Finance and Procurement Article to specifically authorize the use of opioid restitution fund revenue to cover the operating expenses and personnel costs of the Opioids Enforcement Unit of the Attorney General's Office. The unit pursues investigations and brings enforcement actions to discourage and stop illegal conduct, as well as to recover funds for remediation of the opioids crisis. The unit has recovered commitments of about $680 million in recoveries for the Opioids Restitution Fund, and more is expected. Although the law already authorizes the use of the Opioids Restitution Fund monies for law enforcement purposes and administrative costs, which would include the unit's work, Senate Bill 495 provides a more tailored authorization for the funding of the specific activities of the unit. The bill would support the unit's activities based on the benefits that the unit produces. I want to point out that I did provide written testimony as well, and this morning I provided a corrected version that I believe has been swapped in to cover a typo. The division requests that the committee give Senate Bill 495 a favorable report, and again, I thank the chair and the committee for this opportunity.
Thank you. I have some questions for this panel. Senator Reedy?
Thank you, Madam Chair, and thank you, Senator Ellis and Attorney General Brown. I think the work you guys do to go after bad actors is really important, and I know you guys have been working hard, and we've had some good success. So I want to start with that. I guess I hope that was the typo 130.5 million, and you changed it to 13.5. No, I'm just kidding. I guess somebody literally just approached me about this bill, and I thought they were talking about a bill we had on the floor, and so I had some constituents down. And I'm looking at, MACO has some concerns. There's a part of the money that a lot of local law enforcement use for remediation. Sometimes it's for different corrections, things they're doing, other programs. And so this person was in my local department and just mentioned this bill. Is what you're asking for going to take money from what they may have access to? Or I know you were talking about it being narrowly tailored within the administrative cost, so I don't know if you could explain that further.
Sure. So of the $670 million that have been recovered on behalf of the state, 180 million or so has already been received. Those are allocated according to an allocation plan, a subdivision agreement that my predecessor, Brian Frosch, negotiated with MACO and with MML, with the municipalities. And essentially, 70% of what is recovered goes to counties and local government. And they are to distribute those funds in accordance with the settlement agreement. We do not influence how those funds are distributed, the timing of the distribution. And that's also true for the 30% at the state. That is under the Opioid Restitution Fund, the Maryland Department of Health. They've got a program. I think you will hear from some that there are some challenges, both at the state and the local level, in getting that money out. And I would just want to say, without describing in greater detail, that's not our lane, right? We're in the enforcement business. So to answer your question directly, no, what we're asking for will not take away from any state or local funds. What it will do, it will, I hate to use the word earmark, it will identify what I described as that it's called additional remediation amounts, okay, that we have negotiated, 13.4 million, to cover the costs of litigation. So when we're sitting at the big table with multi-states around the table, and many states have private counsel, and they're negotiating their big contingency fee recoveries, we're not at that table because we don't have outside counsel.
We're doing
it ourselves. We're in-house, and we say, hey, look, we're doing it in-house. We have costs. And that's where you get that 13.4 million.
You're assigning that total to the work you're doing.
Exactly. And that 12 million has already come in. When you look at the Opioid Restitution Fund, you don't see that 12 million because it all comes in at once. And what we're asking is for that the Opioid Restitution Fund, as defined in statute, as Attorney Valentine described, that the statute is clear that those monies will be available to the Attorney General to fund the enforcement unit. I'm not going to ask for all 12 million. I'm going to go through the regular appropriation process. When I submit my request to DBM and then the governor, I'm going to say, hey, this year I need 1.5 million, and they're going to say, where are you getting it from, like they do, and I'm going to say the Opioid Restitution Fund. They're going to look at the amended language because you're going to pass the bill, hopefully, and they'll say, oh yeah, you have authority to go into the Opioid Restitution for that amount, and they'll put it in the governor's budget. It'll come to to you and the Budget and Tax Committee, and they'll say, yep, that sounds good, 1.5, here you go, Attorney General. I'll never get the 12 million up front, but I know that the 12 million is there, which will cover me for really the length of this litigation. I'll tell you right now, we have recovered a lot, and I'm not going to share a lot of detail, but when you talk about the pharmaceutical industry, okay, from manufacturers, distributors, national retailers down to local pharmacies, there's a lot of bad action that is still happening out there. And our enforcement unit, we seek to enjoin it and stop it. We seek to recover money for abatement, and of course, to cover the cost of bringing that.
Can I? Yeah, thank you. That's all very helpful, and I'm making some notes. When you talk about bad, this is my second question, and give me an example of that kind of bad action, because Senator Ellis talked a lot about wanting to put more money into enforcement, which, I mean, I'm certainly not going to raise objection to. When you talk about that bad action, can you give me a generic example, maybe?
Absolutely. And in fact, I mean,
what they'll be doing.
The generic action is in many ways related to a case that Baltimore City just brought an action on, and they brought an action against the pharmaceutical manufacturer, okay, and they were successful. But in the presentation of their case, they brought examples of local pharmacies. When you look at their rates of prescription and the number of prescriptions that they were filling per person, they were off the charts. And Maryland has, what's the name of that system where we can see all prescriptions? We can see, I'm sorry? We have a system in Maryland where every prescription goes in. So we look at the data and we're like, whoa, there's a pharmacy over here that's prescribing, I'm making up a number, 100 opioid prescriptions per week per person, and you have one over here that's doing one a week per person. It's like, that's a red flag here. That gives us reason to take a look at that pharmacy.
And you can go investigate.
Absolutely.
And this group, they're going to get, from these funds, it's going to allow, the argument here is that they'll be able to do more of that.
Absolutely. We look at the paper. We talk to former employees. If possible, we talk to current employees. There are sort of limitations on that. We follow all the professional rules of ethics in our investigations, and that's what the Opioid Enforcement Division does. You've heard more in the news about the big pharmaceutical manufacturers, right? Right. And the national retailers. There's still a lot of bad action that's happening out there that is not going addressed.
But I appreciate it. And then this bill is not going to take money away, though, from what local law enforcement or local counties are getting as part of the settlement. Just to reiterate that.
That is correct. They'll continue to get their 70%. Okay. The state gets its 30%, and we're going to get a little piece out of that that we bring in for that purposes.
Okay. Thank you. I really appreciate the answers. Thank you, Madam Chair.
Thank you, Senator. Senator Gall, you're next.
Yeah, and thank you, Madam Chair, and thank you, Senator, for this bill, and thank you, Mr. Attorney General. It's always good to see you. I just have a few questions. I serve on the Opioid Restitution Fund Advisory Council, so I've been part of a lot of these discussions about how these significant amount of funds are being used. I'm curious. I don't see anything in the bill file from Secretary Keller or anybody from the Office of Overdose Response. I'm wondering what those discussions may have been had with her and her agency, and what their feelings are about this.
Sure, and I'll not speak to her feelings, thoughts, motives, or anything.
Yeah.
I will say I'll just use it by way of example.
Yeah.
We were successful this year in engaging the administration to get $1.5 million in the governor's budget from the Opioid Restitution Fund. I think that sends a signal that the administration recognizes that the Opioid Restitution Fund is a permissible and appropriate fund to support the Opioid Enforcement Unit. So you ask, well, why are you here if you were able to get it in the appropriation? Because I don't know who the next governor is going to be, and I don't know what the next budget crisis is going to be next year. And I'll just admit, right, I'm head of agency, and it's like the budget process is tough. It's like, sharp elbows, and it's a bruising battle. And I would really like to take negotiations for the Opioid Restitution Fund off my to-do list so I can fight other battles next year. And again, I think that to go to your question, that the administration saw fit to fund 1.5 from the opioid restitution fund, and I can assure you that they had a very complete, full, comprehensive conversation among the team, because we had it with them as well, that 1.5 million reflects their recognition that this not that they support this bill. I'm not saying, we didn't ask them to support the bill, but it's an appropriate use of the funds.
Okay, thank you for that. And one other question, are other states using their restitution funds in a similar way? I mean, I guess what I'm asking, is there precedent for this? Are other states doing this?
Yes, I can't tell you what other states are doing, because I don't know. I can certainly, we can look into it and let you know. Administrative uses are authorized in the settlements, so other states can use their funds. But I really, really want to hit home, the majority of states use outside counsel. The average contingent fee is 24%. If you apply 24% to $670 million, the state of Maryland would have paid, my math is not that good, I think something like $180 million we would have paid in outside counsel. Think of that.
No doubt.
No one would have said, like, oh, how can you do that? Well, because it's contingent fee. Baltimore City just successfully litigated 2, I think maybe 3 cases. They had big wins in Baltimore City just last year, very celebrated wins. They paid, and this is not criticism, they paid tens of millions of dollars in attorney's fees. I am doing this at a value. I'm asking for $1.5 million a year to fund this unit. I started in 2016 at $150,000. Okay, the unit has grown because we're much more aggressive and robust and shaping a lot of the national settlements. This is a value proposition, and again, I think that's why the governor and his team included it in his budget.
Yeah, I think just one more question, Madam Chair. Is there anything in the settlement agreements defining administrative costs, or is there anything? I'm just wondering if there's anything. You said it can be used for administrative costs, but is there anything broadly defining what that means?
No, I think it's no, there isn't. There isn't,
Yeah.
and I think it's a sort of a commonly accepted term.
Okay.
Administrative being programmatic, the abatement money, right?
Okay.
The money that's used for abatement.
Okay. Okay. All right. Thank you very much. Thank you, Madam Chair.
Thank you. Senator Jackson?
Thank you, Madam Chair. Good to see you, Mr. Attorney General. Thank you, Senator Ellis, for this bill. Just the question I have is, can you just clarify in detail how you are funding the opioid enforcement unit now?
So I think it's a little bit of history is important. In 2016, I'm not sure if this is. It'll come on. Oh, it'll come on. In 2016, when this exploded, this crisis, and attorneys general, Democrats and Republicans around the country said, hey, we got to do something. My predecessor, Brian Frost, said, hey, I got to do that. I got to be on the front line for Maryland. So he took a position out of the Consumer Protection Division, and he funded it with money from the Consumer Recovery Fund. And then he added a few positions over the years, and he added more money. And that was the responsible thing to do, because where else would you get the money? That was the money he had available. And today, we are funding the 6 positions from the Consumer Recovery Fund, but we are on a trajectory to deplete that Consumer Recovery Fund. There's about $18 million in the Consumer Recovery Fund. We spend about, we support over 60 pins in the Consumer Protection Unit from that fund. Now, I bring to you consumer protection matters all the time. In fact, you bring to me consumer protection matters all the time. And we're doing all sorts of stuff, right? Puppy mills, auto dealers, hotels, you name it, right? And I'm funding those with the Consumer Recovery Fund. And I'm also funding the opioid enforcement unit. And that's a diminishing, depleting fund that if we don't do anything, that fund will run out in 3 years. Our recoveries are averaging about 5 to 8 million a year, okay? So this is the time when I really have to move this expense that Brian Frost started in 2016, responsibly so. I have to move it to the fund that it is supporting. I've got to get it out of the Consumer Recovery Fund. because they're not contributing in the Consumer Recovery Fund. So I hope that's answer your question.
Yes, thank you.
Thank you, Senator Jackson. Senator Mounts?
Oh, you don't want to touch it? Oh, I'm sorry.
Thank you, Madam Chair. No, yeah, no lights blinking. This is the Consumer Protection Division. The work's being all done in the Consumer Protection Division. And you talked about all the other functions that that division performs. How are those other functions performing? Are they able to keep up with the caseload?
Yes, we have what I call a discretionary docket, right? So, you know, we manage the cases that we get. You could give me 3 times the number of attorneys and investigators, and I still wouldn't be able to cover all the harms that are done to consumers, right? We are busy. We get complaints all the time in so many different industry sectors. And what is, you know, we are driven by what we identify as unfair and deceptive trade practices. So we're busy and we're fully employed. And we're willing to take on more responsibility, and I'll continue to come back and ask for more money to take on that additional responsibility. The Opioid Enforcement Unit, as you mentioned, is in the Consumer Protection Division, but it is different. It's in many ways, it's almost like the General Assembly created the Home Builder Registration Fund many years ago, and you said, hey, that's kind of a unique sort of consumer problem that we have in the market. And we want the Attorney General to create a home builder, basically sort of like enforcement unit. And what you did back then is you gave me a home builder registration fund that supports those attorneys in the Consumer Protection Division. So in many ways, I'm asking for the same thing. I don't want a new fund. It's already in the Opioid Restitution Fund. But I want an acknowledgement that we've created a specialized unit within the Consumer Protection Unit, and we need to fund it with the resources that it's bringing back to the state in the Opioid Restitution Fund.
Yeah, I guess my question is, I've gotten calls and feedback about consumer protection, and I've never gotten a call or feedback saying that the Opioid Enforcement Unit isn't doing enough. I've gotten a lot of phone calls about saying, you know, we can't get the Attorney General's office to pursue this wrongdoing or that wrongdoing. And that's my one question about what we're discussing today. What about consumer protection? And the calls that I get from constituents are, you know, we can't right this wrong. There's nobody to help me. The state's attorney won't help me. It doesn't qualify for the Attorney General's office. You know, Senator Mounts, I'm stuck. And that's consumer protection, but this is in the Consumer Protection Division. And I'm just wondering, I mean, we have an opioid enforcement unit. It's been successful, and we're talking about growing that unit to be more successful, but this is consumer protection. And all I hear from my constituents is why can't anybody help me?
Right, so we're not actually growing the unit, right? We're already full out, right? We're just funding the unit appropriately so. And with all due respect, your constituents are calling out to you, right? Every time your constituent talks to you about the opioid epidemic and the havoc that it's wreaked on their families and their community, and you're able to say to them that in Maryland, we're stepping up, we're recovering, we're providing resources. This is the Opioid Enforcement Unit. And I won't share the details, but I can tell you right now, when I look out on the horizon and I compare what recoveries we have from the actions we've brought and what recoveries are possible in the actions that we haven't brought, we could double, I think, the recoveries for the state of Maryland. There's a lot of work to do. The pharmaceutical industry, from manufacturer to retail, is still engaged in a very troubling pattern of dispensing opioids into our community. If we stopped right now, I agree, your constituents probably wouldn't say, where's the Opioid Enforcement Unit? But when that money runs out and the opioid epidemic still exists, maybe it's 5 years from now, maybe it's 8 years from now, and they say to you, hey, what is the state doing? You don't want to turn around and say, we cut them off 8 years ago, and we've now run dry on what they brought in. Right. We got to continue the work. And it's not just the money, it's the injunctions. It's getting them to stop doing what they're doing. You would be amazed at what we are seeing in terms of the level of prescriptions into our communities that continues to this day.
Gentlemen, thank you. You've answered my question. We could talk about this for a long time, and I appreciate it, but thank you very much, and that's just something I wanted to share. It was something I took from the testimony and looking at the bill and what I've heard from my district, so thank you.
Thank you, Senator. And Senator Kramer.
Thank you, Madam Chair. And General Brown, good to see you today, sir. And in fact, just this past weekend, the good General Brown and I were having a conversation, and he was sharing how we here in the Maryland General Assembly routinely come in with legislation that increases the demands on the office of the Attorney General. And here is a perfect example of how your office is providing a significant benefit to the state, and you are simply seeking a tiny portion of what that return is that you're providing. And so I very much appreciate the notion that here we do have this resource, that much of it is owed to the hard work of the women and men in your office, and those resources should be shared with your office to ensure that you can continue with that function. No doubt that there are those who are going to try to protect every penny of their turf without recognizing that this is an investment that we're talking about, not just putting money into this fund, but it's an investment in your ability to continue to go out and bring in additional funds that otherwise we might not be seeing, probably tenfold. So I very much appreciate the proposition that has been brought to us under the bill. Senator Ellis, thank you. I think it makes perfectly good sense. And it also then frees up other resources. Again, going back to the point, here in the General Assembly, we routinely say, you know, here's legislation that we think's important. By the way, Attorney General, it's your job to enforce it, and we may be providing you the opportunity to utilize other resources. But quick question: you said that the fund rests within the Department of Health. Did I understand that correctly?
I'm almost certain that Attorney Valentine could probably better answer the structure of the fund and where it aligns.
The fund is with the deputy governor, the lieutenant governor. That's where it lies now.
Okay.
And the structure of the fund, and I know Senator Giles is on the board. There's an advisory board. The Secretary of Health plays a role. And again, we don't want to speak to necessarily the inside baseball in the administration. But you know, the last that we heard, we were talking to the Secretary of Health on this very issue. We were directed to the Lieutenant Governor, who's sort of assuming some of that oversight of the fund, while the Lieutenant Governor is not in statute over the fund. We were directed to the Lieutenant Governor, and it may very well be the case that soon the Special Secretary for Opioid Response, which is Secretary Emily Keller, may be taking point. Look,
I just want to be sure that if the funds are there, that they're being accessible, so that we don't have this large pot of money that somehow is sitting somewhere under somebody's purview and is not being utilized for the needed purposes. That's what I was trying to get a handle on.
Yeah, and Senator Kramer, I'm going to add in the fiscal note, it talks about where the funds reside. Analysis: current law, by the end of fiscal year 2024, Maryland has received distribution totaling over $201 million through 7 prescription opioid-related legal settlements. Most of that funding, $158.4 million, was deposited into the ORF being the Opioid Restitution Fund. So it's deposited in the fund, with $42.8 million distributed directly to local jurisdictions. So it also goes on to say Maryland's Office of Overdose Response, MOOR, M-O-O-R, distributes ORF fund to local health departments, correctional facilities, and community organizations. And it goes on, basically where that money is in the fiscal note. So all the details are in there. I won't go and read all of it, but it has the direct answer to your question.
Thank you. I appreciate that. General Brown, with passage of this bill, if that helps your enforcement actions to on the subject of puppy mills, God bless, you've got my vote. Thank you, Madam Chair.
Thank you, Senator. It's always about the puppies. Thank you to this panel. We have one virtual witness against or unfavorable on Senate Bill 495. Sarah, you can unmute and start.
Thank you to the chair and members of the committee for having me today. My name is Sarah Sample. I'm here on behalf of the Maryland Association of Counties, and we are here in opposition to Senate Bill 495. I want to start by saying that we work very regularly with a lot of members of the Attorney General's office, and they go above and beyond. There is no question about that, and they absolutely deserve adequate operations dollars. Our issue here is really just with the mechanism. And I would also add, this is not the type of bill that we would usually chime in on, but the circumstances around the opioid crisis are unique. And so, in our view, the AG's office is charged with representing and defending the state and its residents, and it's the state's obligation to provide adequate funding. And I don't think that the opioid crisis has changed that, but shortchanging victims by siphoning funds away from community restoration and remediation is a concern that we have. And I can share that county detention centers specifically are feeling the effects of missed obligations from the state too. We're no strangers to this. I can give 4 specific instances, but for the interest of time, I'll give 2. The state mental health transfer backlog is serious. Not thousands, hundreds of people for hundreds of days are in our facilities, and we are covering the cost of care for them. And the state is paying, in a lot of instances, litigation costs, having to defend that lack of compliance. And the second point is, I believe no mystery to this committee, but the state has not effectively funded the medication-assisted treatment programs in our detention centers, despite the requirement by statute. And this is a particularly timely issue because we are working on a consensus bill with Moore and GOCAP to confirm how to get state in compliance on this. And it's for the MAT funding, and it would be through the state's 30% discretionary funds in the opioid restitution fund. And we would fear that this, because we've been working for a long time on this, we would fear that this could compromise those efforts. And we are very disheartened to hear that, the Office of the Attorney General is not necessarily getting supported in terms of the required operations dollars for this. But we do know exactly how you feel. And in our eyes, this particular fund is... Madam Chair, if I just could have one more moment.
You can. Go ahead.
Okay. So this particular fund, we believe, is earmarked to serve victims. And I think that these victims are very different than a consumer protection damage that has to do with a house not being built properly. This is thousands of lives lost instantly. And I think shortchanging them because of operating budget shortfalls is a disheartening path to go down, especially when it looks like structural shortfalls in the state are the worst that they've ever been. So unfortunately, we very respectfully would have to oppose Senate Bill 495. And I'll sit for questions.
Thank you, Sarah. I don't see any questions, so I appreciate your testimony. Oh,
thank you.
Senator Ellis.
Yeah, thank you, Madam Chair. So, Ms. Sample, I think what I hear your testimony, I think you're holding the Attorney General's office responsible for what other state agencies should be doing. Did I hear you correctly? Because you're talking about actually treatment of individuals in corrections. Is the Attorney General's office in charge of that?
I would not say that we are holding them responsible for the deficiencies of other state agencies. No, not at all. We wouldn't even have this money if they weren't doing the work that they're doing. Our concern is that we have been trying for 6 years to get the state in compliance on something that they're required to pay by statute, and that has been very difficult. And we are very close to getting to a point where we might have some resolution on that. And that's the concern of ours, because like the Attorney General mentioned, this fund is going to get depleted over time. And we are just worried about, making sure that we can provide the services to incredibly vulnerable individuals that are in our detention centers. And I think that's our main concern, not that it's their fault. We wouldn't have the money without them.
Well, no, I didn't ask for fault. But if my question was, which agency is responsible to do those things you said not being done properly, like getting the money to those incarcerated? Is that the Attorney General's office? Yes or no? Could you say yes or no?
No, it's not. I would say in statute, I can answer that in statute, it says that the state is required to pay for it. It wasn't exactly clear which agency that would fall on. And the amendments that we have in another bill that we're working on with MORE and with GOCAP is that it would require the state to pay some of those funds out of the opioid restitution fund, but also braid that with other opioid funding potential like SOAR and PIGIF and a few others. So that's what we're trying to establish, is how they are going to be able to get in compliance and that they have the requirement to pay. Because it was left a little bit too broad in the original statute, and that has led to lack of compliance.
Okay, well, yeah, thank you for the answer, because it seems like you're bringing all the frustrations of the counties into this really successful model of collections and very cost-effective way. So thank you, Madam Chair.
Thank you, Senator. I see no other questions for this witness. That ends the hearing on Senate Bill 495. Thank you, Sarah.
Thank you so much.
The next bill is Senate Bill 465. We still have Attorney General Anthony Brown with us, and his panel is Zach Shirley and Tammy Bresnahan. We need to be very careful putting those up because it blocks people's view. We typically don't allow these in committee
Okay,
because
we'll go with that. We can go with that.
I appreciate it.
Yep.
Thank you, Attorney.
And before I start my testimony, I mean, what they depicted is really some of the most horrific cases that we've discovered and caught on video about the abuse of vulnerable adults. And so we'll certainly be able to testify without them and share them, the paper copies. In fact, I think we've offered to share with the committee the video, some of the video footage that we rely on to bring these cases. So thank you, Madam Chair. I want to thank you for the opportunity to provide testimony in support of Senate Bill 465. And what I really want to do is I want to thank the members of the General Assembly, and this committee is really on the front lines with us in our Medicaid fraud and vulnerable victim unit. I'm accompanied today by Zach Shirley, who is the director of that unit. And you have provided us over the last 2 years with the tools and the resources to do more to protect our most vulnerable neighbors and also to protect the Medicaid system against or program against fraud. So the Office of the Attorney General is committed to investigating and prosecuting abuse and neglect of vulnerable adults, particularly in nursing homes and assisted living facilities. Studies show that 1 in 5 adults age 60 and over experience elder abuse, and the true scope is truly underreported. Vulnerable victims are often nonverbal or suffer from dementia, making it difficult for them to advocate for themselves. This bill requires video recording in common areas of long-term care facilities with footage retained for at least 120 days and available for law enforcement inspection. Opponents have raised concerns about the cost of video recording equipment and data storage, but the cost of inaction is far greater in terms of the harm to victims. The opponents will talk about the cost in dollars. We look at the cost of inaction in terms of the harms to human beings. Video evidence has been crucial in securing justice for victims of abuse, as shown in several recent cases, and I'm not going to go through them. They are in my written testimony. The bill limits video recording to common areas, addressing privacy concerns while ensuring protection for vulnerable residents. There have also been concerns raised by the Department of Health and the Office of Healthcare Quality regarding implementation, and we believe that the committee can address them with appropriate amendments. It's not a bill killer. Senate Bill 465 does not create a mandate. It allows the Department of Health to adopt regulations to carry out this section, leaving enforcement flexibility to OHCQ. Instead of an expensive approach, which is what they offer or suggest in their written testimony, OHCQ could consider a self-reporting requirement where facilities document compliance during licensing renewal without additional inspection costs. Again, it is not a bill killer. An amendment can address that concern. So the Office of the Attorney General strongly urges a favorable report on Senate Bill 465 to ensure justice, safety, and accountability for Maryland's most vulnerable citizens. Thank you.
Well, thank you, Attorney General. Next, Zach Shirley.
Yes, good afternoon, Madam Chair and distinguished members of the committee. My name is Zach Shirley, and I'm the Chief of the Medicaid Fraud and Vulnerable Victims Unit in the Office of the Attorney General. When I started this job, I would have never imagined the prevalence of abuse against vulnerable adults in our state. But every month, our unit receives between 30 and 40 reports of vulnerable adult abuse, and that's just what gets reported to us. And without fail, among those complaints are instances of unexplained injuries like bruises, burns, and broken bones. These are injuries that common sense tells us don't happen on their own. But as is so often the case in our work, the victim cannot communicate or cannot remember the incident. These cases are the ones that keep us awake at night, the ones in which, despite our best efforts to find an investigative angle or a thread to pull on, we simply can't prove what happened. But then there's video. Video can change the trajectory of the cases I just described and provide a path to justice. I brought in with me 4 foam boards with screenshots from videos that are 4 recent examples of cases that we were able to prosecute because of the presence of video. In the first, a 74-year-old dementia patient was seen being shoved to the ground by a geriatric nursing assistant. But what you should know is that that man never got up again. He had a broken hip. He developed blood clots, and as a result of his weakened condition, contracted COVID and passed away shortly thereafter. But because this video that was taken by a camera looking down the hallway of his facility was available, his abuser is sitting in prison as we speak. In the second, we prosecuted a direct care provider for assaulting a developmentally disabled man at his daycare program. In the third, a care provider was prosecuted after she dragged a woman across the floor by her feet, kicked her, and pulled chunks of her hair out of her scalp. And finally, a caretaker was found guilty by a jury after a neighbor's Ring doorbell camera caught him assaulting a developmentally disabled man in his care. Those images are proof that Senate Bill 465 can change the landscape of long-term care in Maryland. Cameras are cheap, cameras are effective, and cameras can speak for those who cannot speak for themselves. And for that reason, I urge a favorable report on Senate Bill 465.
Thank you, Mr. Shirley. Tammy?
Good afternoon, Madam Chair and members of the Senate Finance Committee. My name is Tammy Bresnahan. I serve as the Senior Director of Advocacy for AARP Maryland. AARP, as you know, has about 850,000 members, and it's my pleasure to be here supporting the Attorney General's bill today. In Maryland, AARP is committed to protecting the rights, dignity, and well-being of older residents, particularly those in vulnerable situations such as nursing homes and assisted living. We work closely with state leaders, community organizations, and stakeholders to ensure Marylanders have access to safe, quality care and are treated with respect. Through advocacy, education, outreach, we champion strong regulations and laws that oversight to protect against abuse, neglect, and exploitation. We applaud the Attorney General in bringing this bill. You know, I've been before you on many occasions asking for stricter laws and reforms in long-term care. You know, I hate to sound like a broken record, but the Office of Healthcare Quality just has not been doing the job that they're supposed to be doing. We've had to come before you many times and ask you for many laws that will protect our most vulnerable. They're your constituency. They live in your communities, and they deserve to be protected. We ask for a favorable report on Senate Bill 465. Thank you.
Thank you. I think I want to ask this question to Mr. Shirley. As Tammy just said, the Office of Healthcare Quality has not been doing their inspections, as Senator Kramer knows. Do you think if we could regularly follow up and do these inspections, which should be done annually and in some cases haven't been done for 4 years, do you think that would help with the abuse issues?
Madam Chair, yes, is the short answer. But we have to understand that abuse runs a spectrum. And the type of abuse that's going to be addressed by OHCQ being in those facilities and doing those regular inspections is what I refer to as institutional abuse and neglect. And that's where we are understaffed, under-resourced, and mismanaged. And that results in the same type of injuries that you'll see from direct physical abuse, but it's more insidious. It's harder to get at from where I sit because I can't prosecute a facility for not doing their job over the long term. It's not the same as an individual who directly abuses a patient. That's OHCQ's purview. That's what those regular inspections are for. This bill is more about the other end of the spectrum and catching the evidence as it happens of direct abuse by care providers on residents.
Thank you. Senator Kramer, you have a question?
Yes, and to your point, Madam Chair, the OHCQ has totally failed the most vulnerable in our nursing homes in this state for multiple years now. General Brown, I note that they expressed some concern that, as far as I'm concerned, nothing that they have to offer at this point, I believe, is relevant. They obviously are looking to try to kill the bill through fiscal note, again, representing in order to fulfill their already existing state mandated requirements is now going to cost them hundreds of thousands of dollars of additional money when we know they've been receiving huge amounts of federal dollars that we have no idea what they've done with it, but they have not been fulfilling their state responsibilities to be surveying the nursing homes in the state. So it seems to me that legislation like this is helping to fill a vacuum by letting these nursing homes know, yes, there are eyes, watching what's happening, because we know that the OHCQ is failing in its responsibility. Do you think there's a greater opportunity, and I don't want to get caught up in resources, but for the Attorney General's office, were resources taken from OHCQ to go to the Attorney General's office to perhaps help ensure that these most vulnerable in our nursing homes are receiving better protection, perhaps through the Attorney General's office, since OHCQ is completely failing these people? Any thoughts on that? Would you care to opine on that, General Brown?
Well, yes, I will. Thank you, Senator Kramer. We always welcome more resources. However, in this case, I would say probably the answer is no, because that's not the authority that we have. That's not the role that we play. But I do want to use this opportunity to really highlight that the opposition presented by OHCQ and their, I think their fiscal note of 8 additional, they may very well need 8 additional
They
bodies.
don't.
Okay, because this bill certainly doesn't create that additional requirement. And Mr. Shirley can certainly share with the committee his thoughts. He has several on how, in their regulatory capacity, they could implement this with a de minimis impact on how they do business. When they do their inspections, and I know that they're behind, they can simply check for the cameras. Do you have them? When they do the initial licensing and renewals, you can have a form, on the form, self-certify that you've got the equipment, and that's a de minimis impact on their mission and their responsibilities.
You and I are in complete agreement. Thank you, Madam Chair. Thank you, General Brown.
Thank you very much. That ends the hearing for this panel, or ends this panel. We have 3 unfavorables: Allison Siborowski, Dana Kaufman, and then virtually Lorraine Ericott. You want to start, Allison?
Yes. Thank you, Madam Chair, Mr. Vice Chair, members of the Senate Finance Committee. My name is Allison Siborowski, here today on behalf of Leading Age Maryland. I respectfully request an unfavorable report on Senate Bill 465. Leading Age Maryland is a community of more than 150 nonprofit aging services organizations, including skilled nursing and assisted living communities. Our members provide healthcare, housing, and services to more than 20,000 older Marylanders each year. I first wanted to say that we appreciate that the Attorney General's office reached out to us late last year, and we were able to have conversation and give feedback on this bill before it was introduced, so we very much appreciate that. And while we understand the intent behind the legislation, the costs associated with implementing and maintaining the proposed video surveillance system in nursing homes and assisted living programs are significant. Recent cost estimates to comply with this proposed requirement suggest that the initial cost, so just in that first year of becoming compliant, of purchasing and installing the necessary equipment, would range from $50,000 to $200,000 per community. Also, there would be annual ongoing maintenance and storage costs for the required footage. That would be about $40,000 to $80,000 a year additional on for each community. These costs would be particularly burdensome for smaller rural communities that are already operating on thin margins. And again, many skilled nursing communities in particular are serving very low-income individuals who have Medicaid, and the Medicaid rate is only increasing 1% this year. So there's not a lot of extra funds coming in. Further, I wanted to note that the 120-day recording is prohibitively expensive and exceeds industry standards, even for industries where surveillance is deemed crucial, such as police body cameras and marijuana dispensaries, which are pegged at 30 and 90 days respectively. So that 120 days really makes this even more expensive and burdensome. For these reasons, we respectfully request an unfavorable report for Senate Bill 465.
Perfect, Allison. Thank you. Dana?
Thank you very much, Chair, Vice Chairs, members of the committee. My name is Dana Kaufman, for the record, and I'm here on behalf of Lifespan Network. Starting off, I do want to recognize that there was a concern with quality. We heard that during the testimony on the survey bill. However, we do not believe that this bill will have a direct positive impact on resident care. We actually think it will have the opposite impact. We are very concerned about our staffing. Nursing homes and assisted living have one of the most unprecedented workforce crises right now. It is more than hospitals. It is more than any other healthcare setting. And our concern is if we continue to stigmatize and say that nursing homes, assisted livings, and our workers are bad, we are not going to be able to recruit and retain workers for these places, and we need them desperately. And I do also want to point out that when abuse occurs, it is self-reported to OHCQ. It's also reported to the Maryland Board of Nursing, and to a certain extent, it will be reported to the to law enforcement. So there are mechanisms in place. We do not want to have staff abusing our residents by any means, so that there are there's already triggers in place to do that, and for the Board of Nursing to take action. But what we really need to do is we need the state's help. We need to be able to recruit more. Lifespan has a GNA program that took 2 years to get up and running because of delays in the state. We need surveyors in our building, and to a certain extent, it's frustrating to hear, well, the state's not doing their job, so we're going to put this unfunded mandate on you. And it is an unfunded mandate, and it can't be minimized, the cost. Nursing homes are under the same pressure as the state in our budgets. As Ms. Siborowski said, we only got 1%. That does not cover the rising costs of electricity, food, and our staffing. So, and I also just want to point out that assisted livings are a small business. 74% are 9 beds and under, and most of those are owner occupied. So that is a whole different discussion that would need to be had on this bill. So thank you very much.
Thank you, Dana. We're going to hear from Lorraine, and then we'll have questions. Thank you, Lorraine.
My name is Lorraine Arcott. I'm Senior Policy Analyst with 1199 SEIU, United Healthcare Workers East. Thank you to Chair Beidel and the committee for allowing me to testify virtually. And we really appreciate the Attorney General's office work on protecting vulnerable adults from abuse, patient neglect, and poor quality of care. However, we disagree on the approach to address it. 1199 respectfully opposes SB 465 because it fails to address the systemic and institutional causes for poor quality of care for our most vulnerable age. Our members know firsthand how nursing home management decisions to understaff facilities diminishes patient quality care. While cameras might seem like a solution to prevent abuse or neglect, they don't necessarily guarantee better care. In addition, the legislation would authorize video recordings, which may lead to ambiguity as no audio would be captured. Technology to detect abuse and carry out punitive measures does not hold nursing home owners and managers accountable to investing in direct care through hiring more staff and providing proper staff training and supervision. 1199 also opposes as it violates direct care workers and residents' right to privacy. And lastly, installing and maintaining surveillance cameras in all common areas of nursing homes across Maryland require a significant financial investment, and those funds could be better spent on improving staff-to-resident ratios, improving workforce retention through higher pay and benefits, or investing in training programs to enhance care quality. And lastly, I want to note that Attorney General Letitia James in New York has approached poor quality of care in nursing homes through an institutional manner by looking into fiscal responsibility of how these nursing homes and long-term care facilities use Medicaid funds. And they found there was abuse and misuse of those funds that had resulted in neglect and poor quality of care. So we really urge the Attorney General's office to work with 1199 SEIU on solutions that can improve patient care, bolster jobs, and increase fiscal transparency. Effective prevention of patient abuse, neglect, and exploitation requires a multifaceted approach that includes the diverse care team that is committed to providing quality care for residents. And so for those reasons, we respectfully urge an unfavorable report on SB 465.
Thank you, Lorraine. Senator Mounts, you have a question?
Thank you, Madam Chair. And Dan, I've got a question for you, but before I do that, I want to thank the Attorney General's office for the work they've done in prosecuting these cases. I mean, there's no doubt there's a problem. The senator from Montgomery County is very outspoken and very out front. I don't take the same course, but we have a very senior population in my district, namely Talbot County and Dorchester County, and there is definitely a problem. And I'm interested in the bill and listening to the bill and trying to find ways to come up with solutions. And I was wondering if any other states have any other states, to your knowledge, made this requirement or implemented this? Have any other states implemented this requirement that you're aware of?
That I am aware of, as far as the extent to this, right. No, I am not. But I should have also pointed out, but I only get 2 minutes, that there is a requirement in the state, or there's a policy in the state called Vera's Law that does allow electronic monitoring in residents' rooms. So we do have that one already on the books, and there is a process if a resident or the resident's family member wants to have a camera put in the room. And I should also point out that voluntarily, and I think it was alluded to in the Attorney General's testimony, nursing homes and assisted livings actually have voluntarily placed cameras throughout their building. They've put them some in the hallways, by their entrances, but it's really up to the nursing home or assisted living, depending on the cost and how they can manage that. But we do have nursing homes that do have cameras, and I think that is important to point out. And at times, those cameras have been turned over, or I should say those surveillance tapes have been turned over to law enforcement and OHCQ in their in any investigations.
Okay, and then that was going to be my next question, is just to make sure. I mean, I've been in plenty of assisted care facilities, and I thought there were cameras there, but there's nothing that prohibits them from doing that. But I'm also aware there was a work group that considered mandating this in the last couple of years, and it wasn't something I was intimately involved with. And I wanted to know if you had any recollection of that work group and if they had ideas about trying to capture better data to try to prevent problems or try to capture these moments.
So this is when you've been around as long as I have, you do remember things like this. So there was a work group put in, I think it was around 2007. It was a stakeholder work group put in charge of looking at the whole nursing home regulations. And one of the areas that they did look at was electronic monitoring and making it mandatory. Now, they really did focus on resident rooms, but they ended up, after discussion, not putting forward a recommendation for mandatory, one, because of privacy, but also that it does not stop or prevent direct patient care, and they advocated instead for increasing, abuse and resident training, bathroom training, just actually trying to put more effort and money into different proposals. They even mentioned one of the recommendations was, the different assisted devices like low beds and things like that that could help with falls or the buttons. So they did not do a recommendation, to answer your question, for mandatory.
Yeah, and have any nursing homes recently been shut down or prosecuted to the extent they're not allowed to operate anymore?
No, I think the last one happened and it was a Medicaid fraud out in I think it was around Frederick or Hagerstown, but I think that was even pre-COVID.
But that's Medicaid fraud, not care fraud.
Correct.
Not mistreatment.
Correct.
Thank you.
Thank you, Senator. Senator Kramer?
Thank you, Madam Chair. So, Dan, a couple of questions. And nursing home safety is an issue that you and I have been discussing probably for close to 20 years now, and is something that's very near and dear to my heart, ensuring the very best we can do to protect the most vulnerable in our communities. I note that, which I'm a little confused about, your statement that somehow the employees would be stigmatized, that somehow they are bad. We have been living in a world now where security cameras are 100% of daily life. Been in the banking industry for who knows how long. I suspect they don't look up the cameras and think, I'm being stigmatized, that somehow I'm bad, along with every other office setting, business setting. Security cameras are part of the environment. So I'm kind of missing why you somehow have the impression that if we had them in the nursing homes, the employees there would feel stigmatized, as opposed to, hey, it's part of daily routine. And what I can tell you right now, Dana, when I leave this committee room, go back to my office, I'm probably going to pass a half a dozen security cameras. And I certainly don't, have any impression as to it somehow is judgment as to who I am or what I do. So I'm a little bit confused by that statement. Would that not just simply be part of the world that now we have determined, yeah, there is a benefit to having eyes that puts everyone on notice? It gives the residents, the families of the residents, some comfort to know that those cameras are there. And the employees also can have comfort knowing that if an accusation is made that they somehow did something that was wrong, hey, go to the security cameras, take a look. You will see that I did not do anything at all that is suspect. Isn't that so?
Okay. So, to answer your questions. So, one, I do agree with you that we do live in a society now that video cameras are all over. The difference is nursing homes and assisted living, whether or not you are in your resident room or in the common area, it is your home. It is the place where you can congregate with other residents and with your family members. So I do think that that does take a different turn than I'm walking through Costco or Sam's Club or my bank. So I think that is very different. Two, I think it's also...
Well, and can we just pause, and I don't mean to be interrupting,
Okay.
but on that specific, while you're there, but you would acknowledge that these are particularly vulnerable people in that environment, so that it's not just, hey, this camera's in somebody's home. This camera is in an environment where we have very vulnerable people. Yes, they may be engaging socially, but they're very vulnerable, and they are in an environment that is different from being in their home. But please continue. I just wanted to
Okay. And I agree
ask
with you
about that.
they are vulnerable, but that does not mean that they don't deserve the same rights of privacy when they are visiting or when they are walking around in their home. And it is truly their home, especially, and again, when we're looking at this bill, I want to make sure that everybody realizes it's not just the 150-bed nursing home. It's the 8-bed assisted living. It's the 4-bed assisted living that's owner-occupied. And one of our other concerns, and this is going to answer your second question, is, cameras are put into some nursing homes and assisted livings have made the decision they want to have those cameras. Whether or not it is for the safety of both the nursing home and the resident, the nursing home workers or the residents, but they've made that decision. But what I am also concerned with is the intent of why these cameras are going up and the message it's saying, and it's actually right in the bill. It says, after I put my glasses back on, for the purpose of detecting the abuse, neglect, or exploitation of residents. It's not for safety. It's not to, if a resident has fallen, you can get there sooner because you'll see it. That's, that's ongoing surveillance. It is for a specific reason to detect that you are abusing, neglecting, and exploitation. That sends a message. And that is a message I think we have to stop sending to individuals if we want them to work in our communities, and we desperately need them to work. I also wanted to point out, too, that, these cameras, there's a lot, and it was kind of said before, but the ambiguity. So you have a camera, and it's 120 days. And, what also concerns me about this bill is there is no trigger for turning over that film. I don't know if it's a film, it's a tape or whatever. I'm not real good into tech anymore. But it basically says, on request of law enforcement or state personnel in the ordinary course of their duty. Who is state personnel? And what is the ordinary course of their duty? How do they get this tape?
But you would agree that's something that could be clarified?
I think it would.
If that were in particular the concern, that could easily be addressed and clarified and defined. And I'm confident the Attorney General would welcome the opportunity to put a fine point on that and make sure that we don't have ambiguity.
But I think that goes back to that the reason for this is for, as was said, it's for persecution or prosecution of being or being able to go back. And with these cameras, there's camera angles, there's no audio, there's ambiguity, it could be, 4 months old, and you're looking at something. So again, I think that is my concern, is the reason that we're looking at, when I think that the state should really be focusing on what it should be doing and not an unfunded mandate. I agree with you, and we've talked about this. Surveys, they used to be done like clockwork. You could almost put it on your calendar. A nursing facility would know that if they got surveyed in March of 1999, they were going to get surveyed in March of 2000, and it was clockwork. And now it's not. And we need to put our resources back into making that happen. And I know you and I are 100% in agreement with that, but that's where the focus needs to be. It also needs to be on other state processes that are failing the nursing homes, like our GNAs. We have GNAs, geriatric nursing assistants, and until the bill finally takes effect that the chair put in last year, they can't work if they don't have an exam that's administered by the state. And too often, we are having to let them go because they haven't been able to get that exam because the state has not had enough testing sites.
And I appreciate all that. Thank you, Dana. I do, but I'm not convinced that these issues are mutually exclusive, that somehow you put in, greater resources. That's a wonderful thing. But that doesn't mean we should not also simultaneously be doing our best to ensure the health, well-being, and safety of the residents of the nursing homes. But thank you. I appreciate it. I always enjoy having this conversation with you. Thank you, Madam Chair.
Thank you, Senator Kramer. Dan, I have a question from something that you said.
Mm-hmm.
You mentioned that some nursing homes have opted to put cameras up.
Correct.
Do we know if they're having any additional problem hiring people since they have cameras?
That I do not know. And I think it would also depend on where the cameras are and the reasons and how they're used. But I didn't get into that level of detail. But I was interested to find out how many did have them and, you know, where they were.
I think we're going to have a conversation offline. Thank you very much, Dana.
I welcome it.
I don't see any other questions for this panel. Thank you very much. We now have 2 virtual favorables. Jessica Spraker. We'll start with Jessica. There we are. Thank you.
Good afternoon, Madam Chair and members of the committee. My name is Jessica Spraker, and I'm a staff attorney at Maryland Legal Aid. I'm here today to express Maryland Legal Aid's strong support for Senate Bill 465. Maryland Legal Aid provides free legal services to some of the state's most vulnerable residents, many of whom reside in skilled nursing and assisted living facilities. We regularly hear from clients who have suffered neglect, abuse, and unsafe conditions in these facilities. For example, we represented a client with dementia in a memory care unit who repeatedly wandered into unsafe areas due to inadequate supervision. Video monitoring could have documented the facility's failures and prevented harm. Another client in a nursing home was denied meal deliveries. In cases like this, video recordings in the dining areas could verify neglect and hold facilities accountable. Unfortunately, there is no current law requiring video monitoring in these facilities, leaving residents at risk and making investigations difficult for families, regulators, and law enforcement. Senate Bill 465 would change that by improving transparency, accountability, and safety. This legislation will not only prevent future incidents, but also provide critical evidence when abuse or neglect occurs. It will give families peace of mind, ensuring facilities uphold the standard of care required by law and protect those who cannot protect themselves. On behalf of Maryland Legal Aid and the many residents we serve, I strongly urge a favorable report on Senate Bill 465. Thank you for your time.
Thank you. Could you talk any faster, Jessica?
Sorry.
You got it all in a minute and a half. Thank you. Do I have any questions for Jessica? No questions. Thank you very much for your testimony. Our final witness for this bill is Robert Doyle, I think. There he is.
Yes, ma'am. Thank you. Thank you. Good afternoon, Chair Beadle and the Vice Chair and members of the Finance Committee. My name is Bob Doyle. I'm testifying on behalf of the Maryland National and Retired Federal Employees, or NARF, representing about 317,000 annuitants and current federal employees in Maryland. For the protection and benefit of our members and all Maryland seniors, we urge the favorable report on 465. Thank you for Attorney General Brown introducing this, and for President Ferguson for requesting this bill, President for introducing it. We have a statement. I just want to highlight a few things. I want to echo my colleague Tammy Bresnahan from ARP of the great need for this bill. One of the senators had asked in the question session, was this the first state to do this? When I look through the things to get ready to testify here, I think that Maryland would be the first state to have required video camera installation, which I think is terrific. This is a very serious problem. I looked at some data. Some people have mentioned this already. The Attorney General's office gets dozens and dozens of these cases each year. It's clearly a serious problem, and these are criminal acts, and we need to do what we can to help the people who are subject to these. Also, there was a task force more recently than 2003. It was 2023. In fact, let me read you a sentence from their interim report to the governor. They said many people are getting older. With the expectation of serious mental or physical infirmity or dependence increasing with advanced age, there is reason to suspect the incidence of abuse and neglect of older adults in Maryland will rise as the population increases. This was a 2024 interim report of the task force on countering elder abuse. I want to thank you for the opportunity to testify today, and we look forward to a favorable report on SB 465, and also thank you for the opportunity to virtually, although I'm in Edgewater, it's not snowing right here right now. Thank you.
Thank you, Mr. Doyle. We appreciate your testimony. Do I have any questions for Mr. Doyle? Thank you very much. No questions. Then ends the testimony on Senate Bill 465. Next, we have Senator Charles here for Senate Bill 539, Health Occupations Prescription for Children Subject to Shared Custody or Visitation Schedules. And Senator Charles, it's just you. Thank you.
Good evening,
Madam Chair and Vice Chair Hayes and the honorable members of the Finance Committee. For the record, I'm Senator Nick Charles, testifying in support of Senate Bill 539, which is, in theory, a simple bill. But as we all know, in Annapolis, nothing is as simple as it sounds. But what this bill would require is when there is a custody arrangement in place for folks who share joint custody or for folks who share some level of visitation between both children, to curb a lot of the fights and a lot of the disagreements between both parties. What we're asking is that the healthcare providers would be required to be able to issue 2 prescriptions for each drug prescribed to a child if a parent presents a court order or a court-approved shared custody or visitation schedule. It's fairly simple, and some situations you have medicine that is being given in a 30-day dosage, and one parent may have the child for 10 days. And so what we're asking is that 20 days go, there's a prescription that's filled for 20 days for one parent and 10 days for the other parent. This legislation addresses a critical issue for a lot of families navigating shared custody or visitation arrangement. Currently, parents in shared custody situations face a lot of logistical and legal challenges when managing their children's medications. And so what we're hoping to do is alleviate a lot of this. Some of this sounds as if it should be down in JPR with me, but because we're dealing with healthcare, this is something that has to be addressed here because you guys have oversight of this particular issue. But just imagine one party holding the medication and not allowing the other parent to get the medicine for the child, and the child truly needs it. You're stuck in a position when you have to go file emergency petitions to go to court to deal with something that could be done as simply as going to the physician that is prescribing the medication and them putting it just enough for what's based off of the shared custody arrangement. It's, as I said, it sounds simple enough, but after further communication with just about everybody who has opposed the bill, what we have found is that we need a lot of work to work through the summer on this bill. But I'm hoping we can still I got a lot of friends in this committee. I'm still hoping and hopeful that we can get this bill moved to such a way that we can make some change to impact a lot of families that are being impacted themselves on this issue. It's about fairness, and it's about alleviating a lot of the fights that are happening within our communities and making things simplified. And with that, Madam Chair, I ask for a favorable decision from this committee that you guys support this bill. And if you don't support it, I am fine with making a huge amendment to turn it into a summer study that we can work with the insurance companies to figure out a resolution to make this happen.
Thank you, Senator. It all sounds so simple, doesn't it?
It does.
Do I have any questions for Senator Charles? Okay, we have no other favorable witnesses. We have
22 unfavorable witnesses.
No, only 4. Only 4. So first we have Sarah. I think Sarah Price is here in the room, unfavorable. Sarah, are you here? Here she comes. Sarah's unfavorable. And then we'll have 3 virtual unfavorables.
Good afternoon, Madam Chair and honorable committee members. Sarah Price here on behalf of the Maryland Association of Chain Drug Stores. We are sensitive to the issue that is trying to be addressed here. Absolutely understand that we're trying to address the logistical issues and solve some conflicts between parents. But unfortunately, we do have some concerns about the way that this would actually play out logistically in the pharmacy. This bill, I would say, is a bit of an improvement over last year, which would have been a double prescription. This year, splitting it up, it sounds better on paper, but it doesn't address the problems of how this would be covered by insurance or how it could impact pharmacies that are continually audited by PBMs. If a prescription is if one amount of medication is split up into 2 prescriptions, there's the chance that only the first prescription that's picked up would be covered by insurance. And there's also issues around the refill limits that are placed on certain medications by insurance companies, where if you've already picked up what you know to be part of your month's supply, but you have already picked up the first prescription, there could be a restriction on even being able to get the rest of the medication within the time frame that you would need it. There are also maybe some concerns around medications that are taken on an as-needed basis. It's hard to predict when someone may need to take that medication, so you may not end up with the correct amount at the correct house. Hopefully, we look forward to maybe being able to address some of these issues over the interim, should the committee choose not to move the bill, but in its current format, we would urge an unfavorable. Thank you.
Thank you, Sarah. I don't see any questions. Oh, I do. Senator Washington, Attorney Lehman, thank you.
Thank you. Can you just describe to me how, has something like this been done in other states? Other states do split the prescription for kids?
If so, I'm not aware of it, but I can look into it and get back to you and see if that's the case. I can find out how our members in other states have handled it.
Yeah, I'm looking at some of the testimony. It does say it's an increased burden on practitioners, but the bill really states that they're trying to make a compromise to ensure that both parents have access to the medication in case someone forgets. I don't think that's a burden on it's more of a burden on the parents than it is on, I believe, the pharmacists. What ways are some of the pharmacies accommodating parents that want to have these types of prescriptions split so that both parents can have access to it?
Well, a parent could always ask for 2 labeled bottles and then split you pick up the full amount and then you can split it into the 2 separate labeled bottles.
You can do that now? You can ask for that?
I believe so. I think you could also get them split up into separate blister packs, so you're popping 1 pill out at a time. There are some concerns about if a pharmacist is being presented with a visitation schedule or a custody agreement, that it's not really their expertise and to try to understand the legal documentation there. So that was one of the concerns that came up. And then I think it's the insurance issues is a big part of it, is making sure that all the full medication can actually be covered, and if this would introduce issues with pharmacies being audited, especially if you are separating out or making multiple prescriptions for controlled substances.
Got it. Okay. Yeah, I think it's something to consider, especially when families, there's everyone wants to be involved in a child's life, especially if a child needs medication and they're prescribed for it. There should be a method in which I believe the pharmaceutical companies should come up with to help address this issue that's happening.
I would love to speak to the insurance companies about that.
Okay.
But I agree with the intent. It's just some logistical issues that go the whole way up the chain, not just right there at the pharmacy counter.
Thank you.
Thank you, Senator. I don't see any other questions for Sarah. Thank you for your testimony. Virtually, we have 3 unfavorables. We're going to start with Ms. Horton.
Hi, good afternoon. My name is Aaliyah Horton. I am the Executive Director of the Maryland Pharmacists Association. We're the professional society for pharmacists, student pharmacists, and pharmacy technicians. And I do want to thank Senator Nick Charles for bringing this cause forward to ensure that children are adherent to their medications. We recognize that. I also want to say ditto on everything that Ms. Price mentioned, and I submitted testimony for the record. One of the things that I will say is that this should really be an insurance bill. It's not a matter of the prescriber being able to write a prescription. They can generally do what they want. They can write 2 different prescriptions. It's the matter of being able to deliver on that prescription in a way that actually doesn't cause more issue when the parents go to the pharmacy. Because as Sarah mentioned, one person will be able to get the fill, the other one will not, based on things that are beyond the pharmacist's control. And we believe that that would cause challenges there. Also mentioned that if the parent asks for another vial that's labeled, all the different packaging that needs to go with it, the pharmacy can duplicate that. It's a matter of essentially duplicate prescriptions in the patient's file, that are at the same time. It just can't be done. It's got to be directions by the insurance to allow it, and protections for pharmacies against PBM audits for delivering on that, should insurance allow pharmacies to dispense those medications. And as I mentioned, I have additional testimony that was submitted for the record, and I'm happy to answer any questions.
Thank you, Aaliyah. Any questions? I don't see any questions for you. Thank you for your testimony. Christopher Rosinsko?
Yep, that would be me. Good afternoon, members of the committee. My name is Chris Rosinko. I'm the president of the Maryland Board of Pharmacy. I'm also an employee with Johns Hopkins Health System, so the views expressed here are my own, not necessarily those of Johns Hopkins Health System. But I'm here today to testify on behalf of the Maryland Board of Pharmacy and the Maryland Board of Nursing as well, in opposition to the Senate Bill 539, Health Occupations Prescriptions for Children Subject to Shared Custodies. I want to begin by saying that the sponsor of the bill did reach out to the Board of Pharmacy, and the board informed, much like you just heard Aaliyah say, that nothing prevents a pharmacist from providing the custodial parent with an empty vial along with an extra prescription label to share with the non-custodial parent so that both have appropriate storage and prescribing information. But as the bill is written, it imposes an impossible and inappropriate responsibility on both the prescriber and pharmacist to review and evaluate the complex legal custody documents to ensure that the prescription drug quantity issued accurately reflects the percentage of custody awarded to the parents. Reviewing legal documents is not a provider or pharmacist's expertise and can put them in a very difficult situation if interpretations or conflicts arise. Prescribers and pharmacies already practice under high stress, high volume conditions. They don't have the time or resources to do this. Having said that, the bill represents issues for pharmacies, pharmacists, and staff in general. As you heard Aaliyah say, prescription insurance companies generally reimburse a claim for a specific patient and drug. Providing each parent with a separate prescription often complicates that, and it would appear as though there is a duplication and the insurance may only cover one of those. Also, federal law does not allow pharmacists to split a prescription for a controlled substance into two separate. Moreover, the Maryland Prescription Drug Monitoring Program, PDMP, may cause the prescriber and or patient to be flagged for extraneous prescribing or filling due to the duplication of the prescriptions, resulting in delays of care or concerns of prescribing practices. For these reasons and the reasons shared in our written testimony, along with the Maryland Board of Nursing that I asked you to provide an unfavorable report for this bill. And I will also take any questions.
I'm checking for questions now. Thank you. I do not see any questions, but we appreciate your testimony. Thank you. And
Thank
finally, Mr. Massoud.
Good afternoon. Good afternoon, Madam Chair, Vice Chair, and members of the committee. My name is Amir Massoud, and I am a commissioner for the Maryland Board of Pharmacy. I'm also employed at Safeway Pharmacy, and the views expressed here are my own and do not necessarily reflect the policies or positions of Safeway Pharmacy. So I echo the sentiments of our board chair. As a pharmacist, obviously, I think currently, we are able to give 2 vials in those situations I've described, where the parents can have access to the medications that they need with the label so that they can be able to distribute the medication to a child between the 2 parents. Given the fact that, like Aaliyah mentioned, with the insurance companies and everything and the regulations that we have with regards to controlled substance dispensing, right now the systems are just not in place to be able to get 2 prescriptions, kind of processed at the same time for the same patient. So obviously with regulation changes from an insurance company perspective, that's something we can definitely look in the future. But the way everything stands today, the system is just not designed to do that. So that's all I had, but I'm more than happy to take any questions.
Thank you. Do I have any questions for this witness? I see no questions. Thank you for your testimony. That ends the hearing on Bill, Senate Bill 539. Thank you very much. Senator Lamb, you're back just in time. We're going to start with Senate Bill 486.
I have another question.
This is School Health and Wellness Personal Assessment and Maryland Council on Advancement of School-Based Health Centers. And Senator Lamb has with him and his panel William Kress, Robin Elliott, and Liz Elliott.
All right.
Thank you. Good afternoon, Chair Beidle, members of the committee. Here to be able to testify and introduce Senate Bill 486. For the record, Clarence, I am Senator District 12. So this is a follow-up to the Commission to Study the Healthcare Workforce Crisis, one that the chair knows quite well. And through the work of that commission, it was clear that one of the biggest barriers to addressing our school health workforce is the lack of clear accounting of the actual shortage of school health nurses. The main goal of this bill is to task the Maryland Department of Health and the State Department of Education to jointly assess the provider-to-student ratios and vacancy rates for several school health providers. Additionally, the departments must solicit stakeholder feedback on what more can be done to help improve recruitment and retention of school health providers. Having this data will help the state better direct resources towards addressing those shortages. So having this data, I think, will give us a roadmap to be able to look at how we might want to be able to target resources or help address some of the barriers. This bill also adds a school nurse to the Maryland Council on the Advancement of School-Based Health Centers. I am the Senate representative to this council, this statewide recognized council, and can tell this committee firsthand that we have frequently run into issues where the Council on the Advancement of School-Based Health Centers has had a question that could be answered by a school nurse, but we didn't have one present or in attendance as part of the council. Thus, having a school nurse on the council could help meet one of its primary goals, improving integration between school-based health centers and the school system itself. You'll note here that there's a fiscal note that says that the Department of Health and MSD could comply with this bill with limited increased resources. Certainly recognize the department is very concerned. I think there is a little bit of inflation in how much effort or time is required just to be able to collect data. There's not obviously an intention to have to hire a new individual to be able to collect this data that I think it can be collected with the current resources of the department. So, but would be open to, for example, reducing the frequency of the assessment that would still be required under this bill if that helps reduce the fiscal impact as well. So with that, that's the bill. Happy to turn it over to other members of this panel.
Robin Elliott.
Good afternoon. Robin Elliott. I'm here on behalf of the Maryland Association of School Health Nurses and the Maryland Assembly of School-Based Healthcare. In strong support of this bill, I'll just tell a little bit of a story, and that is I've worked on a number of bills related to school health nurses over the years. And each time I pull the same set of data, which is from 2018 and 2019, that's attached to your testimony, and that is the most recent data that we have. So this bill asks the Department of Health, because they're doing a lot of great work already on health professional shortages, and it asks them to round out that data more frequently. Because school nurses work as part of a team at schools, the bill also asks for data on speech pathologists, school psychologists, school counselors, occupational therapists, the whole spectrum of school health and wellness professionals that we need in order to keep our children and students in school and healthy. Very much would appreciate support for this bill. We know that data is really what we need to start with in order to address the underlying shortages. Thank you so much.
Thank you. The other Ms. Elliott, would you like to go?
Absolutely. Full disclosure, members of the committee, we are not related. Yeah.
That we know of.
That we know of. Fifth cousins, perhaps. I am Liz Elliott. I am here representing, school nurses across Maryland. I work very closely with Robin Elliott. I'm the president of the Maryland Association of School Health Nurses. I live and work in Montgomery County, and I have been a school nurse since 2009. And school health is an absolutely amazing, incredibly important resource for the health and welfare of all of us. Students need to be healthy and safe to be ready to learn. And school nursing got its start back in the very early 1900s in New York City. And it became exceedingly evident at that time the impact that a school nurse has on health and on decreasing expenditures in society, because parents can be at work, and then we also don't have those additional expenditures in the healthcare system. And the issue, I think, in Maryland, we all know there is a nursing crisis. It's particularly acute in public health, but we don't really have current data. And we absolutely need current data to provide to this body to make well-informed decisions about what do we do next. And so I urge support for this bill. You know, we would definitely be open to perhaps decreasing the frequency, but it's really important information so we can make better decisions. I appreciate your time. Thank you.
Thank you. And finally, Mr. Kress.
Thank you, Madam Chair, members of the committee. My name is Bill Kress. I'm here today on behalf of the Maryland Nurses Association in support of Senate Bill 486. I want to thank the sponsor for his sponsorship of this important bill. I would just quickly concur with the panelists at the table. It's really important to get this data and understand what's going on in the school systems with respect to healthcare providers and what needs to be done to further bring in additional providers into the system. Thank you, Madam Chair.
Thank you. I see no questions and no other members to testify, so thank you very much. That ends the hearing on Senate Bill 486. Senator Lamb, your next bill is Senate Bill 448, Maryland Medical Assistance Program Self-Directed Mental Health Services Pilot Program. And you have Courtney Bergen, Michelle Livshin, and Lauren Tenney as your board. Might be Tenney.
Tenney.
Michelle and Lauren are virtual, so they'll be part of the panel, but
All right, so good afternoon, Chair Beidel, members of the committee, here to be able to introduce and testify in support of Senate Bill 448, which seeks to ensure that Marylanders with mental illness will have a strong voice in development of their mental health care plans. For the record, Clarence Lamb, Senator District 12. Over the last year, we have heard and seen much news about how important self-directed care and services are to Marylanders and how it has allowed them to live fulfilling lives in their own communities. Although this bill is not directly related to the state's current self-directed services, it is seeking to give our constituents with mental illness more direct participation in their care. The self-directed care model is based on a notion that patients belong at the very center of any discussions that are had and decisions that are being made regarding their health care and are in their own driver's seat when it comes to the actual provision of health care services. Through self-directed care, Medicaid resources are channeled through the Maryland Department of Health directly to patients, thereby making patients the administrators of those resources. This will ensure that they receive only the services they need, and likewise that they are not forced to receive or participate in services they don't need. At the heart of this bill is the notion that the complement of services meant to help an individual with a disability live a full life are most effectively deployed when they are put to work for and directed by that individual, not applied to or on top of that individual. Self-directed care is not only a more effective care model, the ability to tailor services based on each individual's needs also makes it a more efficient care model as compared to the other traditional models that are out there, which subjects patients to monolithic institutional systems that can oftentimes lose the nuance of each individual's own patient experience and preferences. As I mentioned previously, our state has already provided self-directed services for Marylanders with developmental disabilities. Excuse me. Their lived experience is enhanced because they're able to determine what their own happiness, health, and well-being look like, and they're empowered to pursue the same through self-directed care. We exclude Marylanders with mental illness from being able to engage in self-directed care because as a society we believe that people with serious mental health needs are not able to make their own decisions. However, There was a time when, when we, however, there was a time when we thought the same about people with developmental disabilities, and such individuals were often confined to institutions. I hope from your experiences with Marylanders who have visited your offices that you can see that people with disabilities are fully capable of engaging in their own care and should have the right to direct their care as well. This is not a drastic measure by any means. This is a pilot program that will gauge the effectiveness of such a program by assessing the experiences of just 100 qualifying participants. At the heart of this bill is the notion that the complement of services meant to help an individual with a disability live a full life can most effectively do so when they are put to work and directed by that individual, again, not applied to that individual. This bill is ultimately about independence, autonomy, and self-determination, and finally ensuring that all Marylanders, including those with developmental disabilities, enjoy those rights to have the maximum degree possible of independence. And with that, would appreciate the committee's consideration of favorable report and turn over to Ms. Bergen and other members of the panel.
Good afternoon, Madam Chair, members of the committee. My name is Courtney Bergen. I'm an Equal Justice Works Fellow at Disability Rights Maryland, and I'm asking for your support on SB 448 because this bill will really help DRM's clients who are currently stuck in hospitals primarily because they can't get the services they need to live in the community. As Senator Lamb alluded to, many of our services are one-size-fits-all services. So people who don't fit into those systems often get stuck. They get stuck in institutions, they get stuck in our emergency rooms, and they're not able to be part of our communities and give back in ways that, many of them have incredible gifts where they could be part of their communities. Importantly, this bill has also been trialed in 6 other states, and it's been incredibly effective at improving people's experiences of mental health care. And what that does is makes it so people are more likely to voluntarily participate. It reduces the costs of our care, and it greatly improves outcomes in terms of reducing institutionalization and also reducing involvement in our forensic systems, which we know currently have huge backlogs. So this bill could really be a multifaceted solution to many of the issues going on in our state and also address budget issues. In fact, Florida's program, which was implemented first in 2002 and has been going strong for over 20 years, in today's dollars, costs about $300,000 a year in total. It's far less than almost any other service that we are currently providing. So we believe this could be a really important solution. And just to give you an example of one client I have currently, this client has been kicked out of numerous programs primarily because she can't get appropriate treatment for her obsessive compulsive disorder. She's been institutionalized in our state hospitals. She's ended up in nursing facilities when she just needs some targeted specialized services. So she could be more successful in the community if she had a program like self-directed care. So with that, I would ask for your support in this bill, and I'll pass it on to other members.
Thank you, Courtney. Michelle, a virtual testimony.
Thank you, Chair, Vice Chair, and committee members for the opportunity to speak today, and tremendous thanks to Senator Lamb for sponsoring this excited and much-needed bill. I'm Michelle Lifshin with Honor Own of Maryland, asking for a favorable report on SB 448. We represent a statewide network of more than 16 peer-operated wellness and recovery organizations who served nearly 7,000 people in the last year, and we see a great need and potential for expanding self-directed services to people with mental health disabilities. Marylanders living with complex mental health disabilities experience barriers accessing effective care and often have major unmet needs related to social determinants of health. Self-directed mental health services put consumers in the driver's seat of their health care through a combination of support and funding to overcome their unique barriers they face in their recovery journey. In partnership with a support broker and fiscal intermediary, consumers create a plan and budget for the specific goods or services they need to get well. This might include access to transportation, medication copays, assistance with housing stability, vocational support, or other needs that put them on the path for self-sufficiency. This type of program coordinates available resources inside and outside of the traditional system through a choice-based approach. We know that a one-size-fits-all approach doesn't work in behavioral health. Mental health inclusive self-directed programs are active in 6 other states, and research shows great outcomes. This bill will put the right resources in the right place at the right time for each unique individual, and we urge the committee for a favorable report. Thank you.
Thank you. And finally, Lauren.
Hey, everybody. Thank you so much. I'm Lauren Tenney. Thank you for letting me testify today. I guess I'd like to start by saying that I did submit written testimony, so I'm just going to pull some parts from that I think are really relevant. The first is that to consider that the right to self-determination is not a privilege. It's a fundamental right. And that's part of what SB 448 does, and I ask you to support it with a favorable response. I feel like for this bill of self-directed services, as well as many of the things that have come up today, and I'm sure come up on a regular basis, if the statewide Olmstead plan was being enacted, a lot of the struggles that people find of getting services met across systems may be answered. And this bill definitely meets the spirit of what the Olmstead implementation plan was about. And so figuring out maybe how to reinvigorate that process, because it does, having a most integrated services coordinating council definitely will be a cost-effective measure in the immediate time and then also long term. So, looking at issues of government efficiency and fiscal responsibility, the bill does offer a cost-effective alternative to long-term psychiatric institutionalization by promoting non-coercive care models, and it aligns with the principles of personal freedom by promoting medical autonomy. I want to just underscore that those who can afford to pay for mental health services out of pocket already have this privilege about making choices about the type of care that they receive. And we know that race, class, sex, gender, sexual orientation, religious, spiritual experiences, and other forms of disability impact court-ordered psychiatric involvement, which this bill would help to alleviate by giving people from marginalized communities, including the LGBTQI2SA community, the ability to make their own choices and have their own voice in that process. Thank you.
Thank you. Do I have any questions for Senator Lamb or this panel? I do not see any questions. That ends a hearing on Senate Bill 448. Thank you all for your testimony. Thank you so much. Senator, the next bill is yours. Senate Bill 447, Hospitals, Emergency Medical Conditions Procedures. And you have Jennifer Mercer and Robin Elliott. You also have Dana Coffin in favor with amendment. Okay. Thank you.
All right, we'll go ahead with this one. Good afternoon, Chair Bidle, members of the Senate Finance Committee, here to be able to introduce and testify in support of Senate Bill 447. For the record, Clarence Lamb, Senator in District 12. I do want to note that this bill is about pregnancy loss, which can obviously be a difficult topic for many people. And there's no question that our country has entered into a new era given the administration that has taken hold at the federal level the last couple of weeks. 2 weeks ago, we were obviously seeing and reeling from a sweeping pause in government funding. And then we also saw that there were efforts at the federal level to access confidential information related to federal employees and also American taxpayers. So we cannot know for certain what the administration's next steps are, and this is really to help ensure that when it comes to Marylanders' lives, that their lives are being protected by our laws. Senate Bill 447 is seeking to codify the protections of the Federal Emergency Medical Treatment and Labor Act, known as EMTALA. EMTALA has been a long-standing federal statute. It requires emergency rooms to treat any patient that arrives in a medical crisis or need. And it also means that patients that are coming into emergency rooms cannot be transferred out without being first medically stabilized, and prevents patient dumping. This has been an important protection to ensure that all patients are able to get emergency care regardless of their ability to pay. After the Dobbs decision from a couple years ago, EMTALA has become more important because the prior Biden administration had issued guidance reminding hospitals that they were required to provide abortion care if that care was necessary to save a patient's life or to prevent serious injury to an individual. There are currently multiple lawsuits working their way through the courts seeking to exempt or write out abortion from the existing federal EMTALA statute. Additionally, it is also very likely that the Trump administration will not continue to interpret EMTALA to cover emergency abortion care. Previously, under the Biden administration, the U.S. Department of Justice was enforcing EMTALA on hospitals to ensure that emergency abortion care was being provided. Under this administration, that's unlikely to be enforced by the U.S. Department of Justice. And so, we oftentimes get a question about whether this is a theoretical issue. This is not. You'll see in your written testimony, there's actually a letter from Rachel Santos about her experience with a patient who initially sought emergency abortion care in another state. This patient was denied services and made a trip back to Maryland at the risk of her own life. She was getting sicker as she traveled, and by the time she arrived at a hospital in Maryland, she was septic, meaning she had a bloodborne infection throughout her body. Luckily, despite this delay, she was able to receive care that saved her life. Additionally, in your packet, there's a story reported in USA Today about a Maryland woman being denied emergency abortion care at St. Agnes right here in Maryland. If these are two stories, such as if there are two stories such as this one, there must be many others who have been untold about patients who needed emergency health care related to their pregnancies that we have not heard of or are unaware of. I believe we must act to protect access to life-saving care, and we cannot rely on federal statute to protect Marylanders, particularly if those statutes are not going to be enforced. We have heard from many advocates that our attempt to protect reproductive health care is well received, but that the original writing of this bill is too broad. It was not my intention to place any healthcare provider at risk for double jeopardy, so to speak, which means facing malpractice litigation at both the federal and state levels. We plan to work with advocates to limit the language to reproductive health care only. So we're going to be narrow scoping this, the language in this bill, which you'll be receiving as an amendment. We're still working through some of those amendments with the Hospital Association, but they should be forthcoming shortly. This revised bill will serve as a state-level backstop to ensure that patients can receive pregnancy terminations in the case that the pregnant person's life is at risk. It will not place Maryland's physicians, other providers, or hospitals in the position of interpreting duplicative legislation with the potential for contrasting interpretations. Certainly recognize that there are many different opinions on abortion in this committee and in this body, but this bill is only talking about the scenarios where a patient is so sick that they need an abortion to save their life, to prevent permanent injuries such as loss of future fertility. And just to be clear, for many women who are being transported to a hospital, oftentimes in severe condition with these types of scenarios, they're being transported by an ambulance. And oftentimes these individuals don't have a say where those ambulances will be going. And so we certainly have some faith-based institutions here where a woman who needs a life-saving abortion in an emergency may not be able to get that care that they need depending on which healthcare facility they end up at, of which they oftentimes have no say where they end up at. So this is an important bill to ensure that life-saving abortion care is available at every emergency department for any woman who needs that, and thus ask for a positive consideration and favorable report on this bill, and happy to turn it over to other members of the panel and take questions at the end.
Chair Beidel, Vice Chair Hayes, and members of the committee. My name is Jennifer Mercer, and I am the Legislative Director of Reproductive Justice Maryland. I'm here today to share our strong support of Senate Bill 447. Since 1986, the Federal Emergency Medical Treatment and Active Labor Act, or EMTALA, has stood for the proposition that no American experiencing a medical emergency should be turned away from the ER due to inability to pay. This life-saving federal law now faces an uncertain future. Litigation in the federal courts, a hostile executive branch, and an unsympathetic at best Congress are the three-headed monster at the gates of EMTALA. We alone cannot slay the federal beast, but we can write a different story for Marylanders. Senate Bill 447 comes at this critical moment. It will require that pregnant Marylanders experiencing a medical emergency must be stabilized at the ER without regard to their ability to pay. News of a positive pregnancy test can mean many different things to the people involved, but one thing is always true. Pregnancy carries certain medical risks, and sometimes even the most desperately hoped for and prayed for pregnancy could go from a dream come true to a nightmare which threatens the mother's life or health. Marylanders facing this horrific scenario need to know that they can expect to be treated at the ER no matter what their financial situation is, no matter what that treatment may be, or which hospital they happen to be taken to. Reproductive Justice Maryland urges you to support Senate Bill 447 and issue a favorable report. Thank you.
Robin?
Good afternoon. Robin Elliott. I'm here on behalf of the Women's Law Center of Maryland and the Maryland affiliate of the American Academy of Nurse Midwives. So from both the legal side as well as the provider side. We do not have a crystal ball. We cannot be certain, but we can look at the litigation that's going on right now. We can look at some of the decisions that have been made in the past couple weeks. And we can say we're fairly certain that the federal EMTALA requirements will not be enforced as we have seen them enforced in the past. Maryland does not have a state EMTALA law, which means if the feds change how they enforce the requirements, there is no statutory protection in Maryland. So what Senator Lamb's bill simply does is it, as he said, creates a backstop. And I know he's working very hard to make sure that that is a backstop that works for all stakeholders. We very much support this effort and would ask for a favorable report.
Thank you. Do you want me to go ahead with the favorable amendment, Dana?
Okay. For the record, Dana Kaufman, I'm here today on behalf of MedChi, the Maryland ACEP chapter, and the Maryland chapter of ACOG. We are in support of the bill with amendments, as was referenced by Senator Lamb. Initially, when we read the bill, we did have concerns. It basically takes the full EMTALA statute with the penalties and causes of actions and put them into state law, while the federal EMTALA law is still there. We were concerned of, kind of like a double jeopardy scene. So we're working with him to narrow it for the intent of the bill and to reduce, to remove the penalties and the causes of actions, and just makes it a requirement so that the intent of the law and the protections that it is meaning to put forward can go through. So again, we welcome the opportunity to continue, and hopefully we'll have a product to you soon. Thank you.
Thank you. Do you have any questions for this panel? Thank you very much for this very good bill. We are going to move to the unfavorables, Laura Bogley and Natasha Mayhew.
Good afternoon, Madam Chair, members of the committee. Natasha Mayhew here on behalf of the Maryland Hospital Association in opposition to Senate Bill 447 as it is introduced. So the hospitals did have a lot of concerns with the original language, which attempts to codify EMTALA into state law, mostly because this would be duplicative and confusing. I do want to be very clear. Maryland hospitals follow the EMTALA law. When people come to our emergency rooms to get treatment, they get treatment, and that includes when it's necessary treatment for reproductive health purposes. I do want to thank the sponsor. He reached out very early on this bill. He has taken our concerns regarding EMTALA into consideration, and so we appreciate working with him on some amendments that would more narrowly tailor the bill to reach his intent. And so we are reviewing those amendments right now with our members, and we look forward to continuing conversation. Thank you.
Good afternoon, members of the committee, Mr. Vice Chair. I'm Laura Bogley, Executive Director of Maryland Right to Life. And on behalf of our Board of Directors, we oppose this bill, which would, as we heard, codify federal EMTALA statute, but not just the EMTALA statute, but the political interpretation and guidance on the EMTALA statute. This bill is an attack on religious freedoms guaranteed by the First Amendment and protected under Title VII of the Civil Rights Act of 1964, which this body must be in compliance with. Title VII requires that employers can grant reasonable religious accommodations to physicians who do not want to participate or commit abortions unless it creates an undue hardship on the hospital. This bill is creating the undue hardship on the hospital by issuing penalties of $50,000 per violation. This bill would force hospitals and emergency room physicians in violation of their rights of conscience and Hippocratic oaths to commit induced abortions under the guise of medical emergencies. Induced abortion is never medically necessary. Doctors perform induced birth or medical termination of pregnancy to save the life of the mother regularly. That is different than what we're talking about with induced abortion. And I'm glad that the senator, sponsor of this bill, actually acknowledged that this bill is about abortion, because the bill doesn't say the word abortion. Neither does the original EMTALA statute, which says that the hospital providers are required to provide care for both patients, the mother and the child. They never say the hospital provider is required to perform induced abortions whose sole purpose is to terminate the life of the preborn human being. The bill would force taxpayers to reimburse providers who were forced to commit these complete induced abortions through Medicaid, which was never intended to pay for elective abortions. It's important to note that due to the reckless deregulation of abortion practices, physicians are encountering women coming in with crisis, incomplete, and failed botched abortions. And this would restrict their religious freedom because they would be induced to perform or complete those abortions in violation of their civil rights. So we urge your unfavorable report, and I'm happy to take questions.
Thank you so much for your testimony. Senator Reedy.
Yeah, thank you, Mr. Vice Chair. So can you talk, Laura, can you talk about what is the EMTALA statute really supposed to be for? Because it's obviously for emergency care, and this bill is really kind of trying to put us into a spot where you have to do it because they're there. So, I mean, can you talk about that?
Sure. So the EMTALA statute, the federal statute, was enacted in 1986. And as I said, there's several times within that statute when it talks about caring for both patients, the mother and the child. Similarly, this bill talks about delivery. It talks about when a pregnant woman comes into a hospital in the process of imminent delivery. It does not talk about abortion. You'd have many more people here opposing this if the bill was transparent and said that it was about abortion. I also want this assembly to understand that there is no law in any state in this nation that prevents medical intervention to save the life of the mother when it's related to pregnancy. For example, ectopic pregnancy, miscarriage, preeclampsia. Those medical emergencies are routinely performed by doctors in hospitals, not by abortionists in abortion clinics. That's legal in every state. But the Biden administration weaponized the EMTALA statute and had HHS issue guidance to tell medical providers that this means they have to perform abortions regardless of their religious freedoms. So St. Agnes, which the sponsor mentioned, is a Catholic hospital. This state was created as the original Catholic sanctuary colony for Catholics to be able to practice their faith. That includes Catholic medical providers and Catholic hospitals. Catholic hospitals, Catholic providers, Christian providers routinely provide medical intervention for women that have life-threatening medical emergencies related to pregnancy. That is different from an induced abortion which sole purpose is to end the life of that preborn child. This bill confuses it. The politicization of the EMTALA statute confuses it and is using fear to induce all of you to comply and to force all of us taxpayers to fund this.
Thank you very much. Thank you, Mr. Chairman.
Thank you so much for your testimony. Are there additional questions? Of course there are. Senator Lamb.
Thank you. To Natasha with the Hospital Association, I know you're listed as favorable, or sorry, as unfavorable, but I'm hoping that once you get the amendments back and MHA is able to look at this, you're on an unfavorable panel now, that we can get you to favorable with amendment. And so, would certainly encourage kind of the continued dialogue on this. I think we are very close to something that the Hospital Association can agree with. And so I do want to just to kind of be clear, though, that, for women who are experiencing a serious illness and they end up in an ambulance, they have no say which hospital is taking them to. Is that correct? They're generally taken to the closest hospital that's open and available to accept beds.
Generally, yes.
Beds. And so you can envision that there are scenarios where a patient is critically ill and needs an abortion to save their life. They have no say in which hospital they end up at. They could end up at a hospital, and we've seen accounts in the media of hospitals here in Maryland that have not provided that care. That's what this bill is trying to address. And those amendments that I think are sitting, we've had this continued dialogue with MHA, are hoping to be able to narrow tailor it just to those scenarios. And so I'm hoping we'll be able to hear back soon from MHA about this.
Yes, we are reviewing the amendments and, looking towards that more narrowed approach that you are seeking to do on this bill. Okay. I will say that, though, when people do come to the emergency rooms in Maryland, and if it is for emergency treatment in terms of pregnancy and otherwise, they will get that treatment. But we do understand the bill's intent, and we'll continue to work with you to get that narrowed down.
Okay, sounds good. Look forward to getting off this unfavorable panel.
All right, Senator Reedy.
Thank you, Mr. Chair. I know we only have a rule about 1 per 1. That's why I've asked again. So I wanted to see if I could ask Natasha a question. Yeah, I figured the position you're taking is a little different being on the unfavorable panel. I was curious, you're talking about, number one, you mentioned if there's emergency care needed, it's provided at the hospital. Nobody's turned away. Do you have any data? We're hearing about this like medically necessary abortions, which is interesting because it's very rare that you actually have a medically necessary abortion at 9 months. So do we have any data on that? Do we have any? Does the Hospital Association or maybe or to your knowledge, the state of Maryland have any data on how many emergency abortions in the 3rd trimester are performed?
I do not have that data. I'm not quite sure who would be tracking that specifically, but we don't have that at MHA.
Thank you. I thought probably not. We actually don't keep track of abortion data in the state at all, which I think is crazy because it's obviously such an important issue that even though we have a constitutional amendment protecting it, we still don't keep track of how many abortions are performed in the state, which I think is pretty crazy. But I imagine that it's very, very rare. So we're kind of straining at a gnat here of trying to like find a way we can punish Catholic hospitals. Not you, of course. You're here to say let's not be too hasty with the way the bill's drafted. But I appreciate the Hospital Association being here to talk about some of the concerns. Thank you, Mr. Chairman.
Thank you, Senator Reedy. Are there any additional questions for this panel? Seeing none, thank you so very much for your testimony. We have 2 people signed up for virtual testimony. The first, Anna Jarvis, is signed up in favorable of Senate Bill 447. Anna, you may proceed when you're ready.
Hi, everybody. Thank you so much. Good afternoon, and thank you, Chairwoman Vital, Vice Chairman Hayes, and the members of the committee for allowing me to testify today before you in support of SB 447. My name is Anna Jarvis, as you said, Dr. Anna Jarvis, and I'm a 3rd-year OBGYN resident physician in Baltimore City. I'm testifying today as an obstetrician because SB 447 is critical to ensuring the safety of our patients. Given ongoing shifts at the federal level, we must create state-level protections. When I think about why this bill is important, I clearly remember a patient who came into the emergency room in the early 2nd trimester with severe abdominal pain. She had a high fever and a high heart rate and had an infection in her uterus that had spread to her entire body. Her labs indicated multi-organ system failure as a result of this severe infection. She needed an emergency abortion to treat her infection and save her life. If she had presented to a different hospital in a different state and her care had been delayed, there is absolutely no doubt that she would have died. She very nearly did, even with our supportive and expeditious care that we provided. I support SB 447 because emergency obstetric care is exactly what it sounds like. It is life and death. I can tell you this firsthand as a physician who spends countless nights and weekends taking care of patients who present to the emergency room needing urgent care. Legislation has far-reaching effects, and it can be extremely damaging for patients when it obstructs care and creates barriers for life-saving endeavors. Please take this opportunity to protect my patients from delays in care and protect their access to life-saving medicine. I am proud and grateful to be a provider in a state with protective laws for reproductive health. I urge you today to vote in favor of SB 447 and protect our patients' ability to access emergency care no matter the indication. Your consideration of this bill is very much appreciated, and thank you very much for your time today.
Thank you so much for your testimony. Are there any questions for this panel? Seeing none, thank you very much. We're going to go on to Ben Sisney with unfavorable testimony on Senate Bill 547. Ben? Ben, you need to come off of mute.
Good evening, Senator, and thank you for the opportunity to be here. Even though I'm reporting unfavorable, I do appreciate the opportunity to speak out and to weigh in important decisions like this before this committee. My name is Ben Sisney. I'm the American Center for Law and Justice in Washington, D.C., and litigate in matters, cases of abortion and pro-life and conscious rights. And I want to just cut right to something here. I've heard it discussed that the shifting, landscape of the federal government and that there's litigation working through the courts is justification for why this bill is being advanced and why it's necessary. But there's something that we're missing here. One is the shifting federal government. The administration may shift, but the Constitution and the federal statutes don't. There are federal legal protections for doctors and healthcare personnel. I'm going to quote from the United States Supreme Court decision. They have broad and comprehensive conscious protections guaranteed by federal law. That's FDA for the Alliance for Hippocratic Medicine in 2024. In that case, they explain federal conscience laws definitively protect doctors from being required to perform abortions or provide other treatment that violates their conscience. Cites a series of statutes, the Church Amendment, the Weldon Amendment, the Coates Amendment. These legal protections exist, and Maryland's effort to move this bill, which I also appreciate that we are openly calling it an abortion-related bill now, I think it's overlooking that the federal legal protection, the reason there's litigation pending in the courts is because of those federal conscience protections for the healthcare providers. And it's not just doctors, it's healthcare providers as well. And so just to be clear, federal law is supreme to state law. There are federal protections for healthcare workers. And I anticipate this bill will pass. But I would urge the committee to consider just simple amendments of nothing, something to the effect of nothing in this bill shall be construed to jeopardize or weaken the conscience rights of healthcare providers, or it will not be construed in conflict with federal law, something to that effect. For these reasons and the confusion and the conflict this bill will cause, and we will be watching it, and we'll add to that litigation if necessary to protect conscience rights, we oppose SB 447. We urge you to report it unfavorably. Thank you.
Ben, thank you so much for your testimony. Are there any questions? Seeing none, thank you so very much. This ends the testimony on Senate Bill 447.
Thank you, Mr. Vice Chair. We are going to go to Senate Bill 458, Senator Guile. Senator Guile, this is your health occupation structural racism training. I think you have a panel. William Kress, Yvette Conyers, Lou Bartello, and then virtually you'll have Lorraine Ericott.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. For the record, Senator Dawn Guile here to present Senate Bill 458. This bill mandates that individuals renewing certain health occupation licenses and certificates complete a training program on implicit bias and structural racism. This program must be approved by the Cultural and Linguistic Healthcare Professional Competency Program. The bill seeks to improve cultural and linguistic competency among healthcare professionals by addressing these critical issues in the healthcare setting. Implicit bias and structural racism, though related, are distinct concepts. Implicit bias is typically unconscious, subtle, and beyond an individual's direct awareness or control. In contrast, structural racism involves deliberate actions or systemic policies that result in explicit discrimination and greater harm on both individual and institutional levels. By requiring this training, the bill aims to equip healthcare professionals with the knowledge and awareness needed to mitigate both implicit bias and structural racism, ultimately fostering more equitable healthcare outcomes. In your packet, members will find a sponsor amendment made at the request of MDH to adjust the definition of structural racism to the totality of ways in which societies foster racial discrimination by mutually reinforcing systems of housing, education, employment, earnings, benefits, credit, media, healthcare, and criminal justice. And I'm happy to accept this amendment. And I would ask for a favorable report on this bill. Thank you, Madam Chair.
Mr. Kress?
Thank you, Madam Chair, members of the committee. Bill Kress here today on behalf of the Maryland Nurses Association in strong support of this legislation. I want to thank the sponsor for putting in this bill. To give you a little bit of background, the American Nurses Association has come up with $1.2 million in funding to deal with racism in healthcare and especially within nursing. And that $1.2 million funding was broken out into 10 grants, $100,000 coming to the state of Maryland. The Maryland Nurses Association has been working on this issue with the University of Maryland, who's developing a system of training that will be offered at no cost to healthcare professionals. So we are in strong support of this legislation. Mr. Bartolo, who is the president of MNA, could not be here today because of the weather, but I do have Ms. Conyers here who can tell you more about the bill and the program at the University of Maryland. Thank you.
Thank you. Ms. Connors?
Yeah. Good afternoon, everyone. Thank you for having me today. I'm Dr. Yvette Conyers from the University of Maryland School of Nursing, Associate Dean and Assistant Professor. As a member of the Maryland Nurses Association and American Nurses Association, working with Dr. Lou Bartella, this is very important to us. We have developed training at the School of Nursing for a long time, and as a content expert, that will be the hat that I will be wearing to develop this curriculum and training for our healthcare professionals. For nursing, it may be with continuing education credit, but for others, it will be up to the various boards to decide that. Thank you.
Thank you. And Lorraine?
Good afternoon. My name is Lorraine Arikat, Senior Policy Analyst with 1199 SEIU, United Healthcare Workers East. We represent over 10,000 healthcare workers across hospitals, long-term care facilities, and federally qualified health centers in Maryland. 1199 strongly supports SB 458, which would embed structural racism training into the license and certificate renewal process for healthcare workers. 1199 SEIU has committed to fighting structural racism in healthcare through advocacy on social determinants of health, higher wages for low-income communities, and increased access to care for communities of color. Structural racism is when laws and policies prioritize certain groups over others, resulting in unequal opportunity in healthcare, jobs, housing, education, and safe environment. To address ongoing racism and mitigate bias in healthcare professionals, acknowledging and educating healthcare workers about structural racism is one step towards an anti-racist perspective that can inform all healthcare education, research, and practice. Providing equitable and unbiased care is the responsibility of all clinicians. And yet we still see unconscious biases and racist attitudes of healthcare workers as a substantial contributing factor to health disparities. SB 458 is an important step towards educating our healthcare professionals about the ways structural racism impacts patients and health care. For those reasons, 1199 supports SB 458.
Thank you, Lorraine. Do we have any questions for the sponsor panel? Seeing no questions, thank you, Madam Sponsor.
Thank you.
We have a favorable with amendment in person, Andrea Mansfield, and then we'll have one more virtually.
Great. Thank you, Madam Chair, members of the committee. Andrea Mansfield, representing the licensed clinical professional counselors of Maryland, in support of House Bill 458 with an amendment. Actually, our client, they really fully support the premise and providing structural racism training. This would largely mirror the implicit bias training that was put in effect a few years ago. They really think that this would help them just for treating individuals, better understanding the patients, the background, historical issues, and so forth. We make them really continuum of care and provide much better treatment. The amendment that they would like in this bill is to allow this structural racism training to be offered for continuing credit. And this is something that they feel that it's going to be a requirement for the continued licensure. They would like to see credit for that. Therefore, they're supporting the bill with amendments, and we're happy to work with the committee, the sponsor, and other interested parties and stakeholders to try to develop what that appropriate language should look like for the bill. But thank you.
Thank you, Andrea. And finally, well, do I have any questions for Andrea while she's here? No questions. Thank you very much. Aaliyah is with us virtually.
Good afternoon, Aaliyah Horton with the Maryland Pharmacists Association, here with the support with amendment. I do apologize, I was watching and there was a delay, so I missed the testimony before me. But I do want to say that we are in support of this bill, but we'd like to add an amendment that adds that it would allow the training that is presented, that the training accepted by the Department of Health be accredited by the Accreditation Council for Pharmacy Education. The language currently has the Accreditation Council for Continuing Medical Education, and for pharmacists and pharmacy technicians that are licensed in Maryland, they have to go through additional steps to get that training approved by the Board of Pharmacy, as well as in their national, the National Association of Board of Pharmacies profile, which the licensing boards use for their renewals. And so on the House side, at least, the delegate sponsor has accepted the amendment, and we would just urge a favorable report with this addition. And I'm happy to answer any questions.
Thank you, Aaliyah. I think you'll find the Senate will probably accept that amendment also.
Okay, thank you.
Do I have any questions for Aaliyah? That ends the hearing on Senate Bill 458. Thank you very much. Senator Guile, Senate Bill 21, the one we've been waiting for all day, Dentist and Dental Hygienist Compact. So we have Senator Guile, Robin Elliott, Jason, and then we have 4 virtuals, Jason Spiegel, Matthew Rossetto, Matt Schaefer, and Christopher Arnold. And we'll go for questions after that entire panel. Thank you.
And thank you very much, Madam Chair. I had proposed to Senator Kramer that perhaps we can settle this by meeting at dawn tomorrow morning on the lawn, but we thought that this might be a more civil approach. So with that, for the record, Senator Don Guile, District 33, here to present Senate Bill 21. This bill was created in partnership with the Council of State Governments, the National Center for Interstate Compacts, and the Department of Defense. After a long and rigorous stakeholder review that included the American Dental Association, the American Dental Hygienists Association, and the American Student Dental Association, and many others, this compact was released in January of 2023. Since that time, it has become active in 10 states, including our neighbor to the south, Virginia, and is pending in 15 others, including our neighbor to the north, Pennsylvania, and New Jersey. The alternative compact you'll hear about today is currently not effective or not currently in effect in any other states. Similar to many of the healthcare compacts this committee has previously passed, the Dentist and Dental Hygienist Compact will enable dentists and dental hygienists to acquire compact privilege and allow them to practice in other active states without having to obtain individual licenses for each state. It will increase license portability for dental professionals, support military families, and improve access to oral health services for many Marylanders. The compact still requires a background check, and once a licensee is deemed eligible to obtain compact privileges, states can take a disciplinary action against a compact privilege holder just as if that person held a license in that state. If any action is taken, it is quickly communicated to all member states, and the action will apply to all compact privileges that a practitioner holds. These safeguards maintain the safety of Maryland dental patients and the integrity of the dental practice. Of particular importance is the support this provides for military families, which are highly mobile and are reassigned to a new duty station often every 2 to 3 years on average. The Department of Defense supports these compacts as a solution for portability so that military spouses are able to continue to work as they move with their families. And I would also note that I am aware that there were amendments made to the Service Member Civil Relief Act requiring certain states to recognize licenses from other states. However, the Department of Defense continues to support compacts because of the continued inherent problems that may be associated with those recognition of licenses under the Service Member Civil Relief Act amendments. A dentist or dental hygienist must apply for a compact privilege in each state where they wish to practice, and states will retain control over who they license and the scope of practice. Per the fiscal note, of course, this would not require additional state resources. We thank you for your consideration, and I ask you for a favorable report. Thank you, Madam Chair.
Thank you. Robin, you ready?
Good afternoon. Robin Elliott here on behalf of the Maryland Dental Action Coalition. And then I'm not signed up because they just made the decision yesterday, but also on behalf of the school-based health centers. And you heard testimony earlier today about dental hygienists and about the wonderful news of having Medicaid now cover adults. That's 800,000 additional people. We were already strained before Medicaid extended to adults, and now we're even more strained. I'm not complaining. It is a good problem to have too many people with coverage who are seeking services, but we do need to use every tool available to get providers here in Maryland. And compacts work. We have seen it in other professions. Maryland has adopted OT compacts, professional counselors, psychologists, physical therapists, and of course, Maryland was the first state to adopt the registered nurse compact. So this is a tool that works. And we think we can leave no stone unturned, given our need for providers. Compacts also work to attract providers to come to and live in our state. Providers are actively seeking states that have the most flexible licensure arrangements, whether it's dental or in other professions. So this bill would send that message that Maryland is forward-thinking, supportive of making sure that we are using all the tools in our toolbox to make sure there are enough providers. Thank you very much. Would appreciate a favorable report. Even Senator Kramer.
Thank you. Jason Spiegel. Unmute, please, Mr. Spiegel.
Thank you, Madam Chairman. I'm Jason Spiegel, President of the Maryland Military Coalition, and I urge a favorable report on SB 21. As Senator Guile alluded to, once Maryland joins this compact, it will support military spouses who move to Maryland and will have one streamlined pathway for licensed military spouses to practice in Maryland when their licenses are in other states. The compact reinforces a commitment to supporting employment opportunities for service member spouses and continues Governor Moore's Year of the Family from last year and is a critical component of reducing spousal unemployment. We do note, however, that this compact is not perfect as it applies to armed forces spouses and not spouses of officers of the Commissioned Corps of the Public Health Service or the National Oceanic and Atmospheric Administration. Military spouses are not required to pay a commission fee for compact privileges, but PHS and NOAA spouses will be. Compacts can't be amended. They must be passed as written, or Maryland is not considered to have joined the compact. That's why we're not here requesting a favorable report with amendment. However, once Maryland joins the compact, we will urge the administration to work with the other member states of the compact to include PHS and NOAA spouses in the compact provision. We want to thank Senator Guile for sponsoring this legislation and ask for a favorable report.
Thank you, Mr. Spiegel. Matthew?
Which one, Senator? I'm sorry.
I don't care.
Madam Chair, I think there's two Matthews.
I said Matthew Rossetto.
Oh, okay.
Oh,
Thank
I'm
you.
sorry. Didn't
That's
not
okay.
hear
Go
that. Thank you, ma'am. Thank you, Madam Chair and committee members. My name is Matt Rossetto. I'm here with the American Dental Association, and we are testifying in favor of Senate Bill 21. The ADA is committed to addressing the issue of license portability because it is something our member dentists are demanding and doing already. Between 2019 and 2022, 15% of all new dentists, which we define as those 10 years or less out of dental school, changed their state of practice. This is a significant jump in mobility and one of the reasons why the ADA joined with our coalition partners to create and promote the compact. I want to talk about two assertions that have been made against this particular bill and address those as best I can and further in questions if possible. There's been an assertion that the compact somehow changes the standards by which a dentist must receive a license. This is not true. Every dentist in America must graduate from a CODA accredited program, pass the Integrated National Board, and then pass a clinical assessment for licensure, which is the same standard that the compact requires. The reason that the compact does not name a specific exam is because multiple states accept multiple pathways to licensure. The compact is agnostic on which pathway is preferable. It is not our place to tell states which exam to accept. The second portion is addressing discipline, and Senator Guile addressed it, but I'll state as well. Section 4D of the compact is very, very clear. A licensee providing dentistry or dental hygiene pursuant to a compact privilege is subject to that state's regulatory authority, and the remote state can revoke or remove a compact privilege. They can impose fines or take any other necessary action. The Maryland State Board of Dental Examiners does, under this bill, and can and should have the authority to take action against those who break the law and those who violate the Maryland Practice Act. We appreciate your support for this bill, or we hope for your support for this bill, and would ask for a favorable report. And I'm happy when this is done to stand for questions. Thank you.
And the other Matt Schaefer.
Thank you, Chair Beidel, members of the committee. Matt Schaefer with the Council of State Governments. CSG, through our National Center for Interstate Compacts, has facilitated the development of all 18 of the active occupational licensing compacts, including the 8 that Maryland is currently a member of. Maryland's also a member of 44 other interstate compacts that are unrelated to professional licensing. As Senator Guile mentioned, the compact was created through a cooperative agreement that CSG has with the Department of Defense. And for almost 2 years, we developed the language in partnership with the ADA, the American Dental Hygienists Association, state dental boards, and the dental education community. The compact is very similar to the compacts that Maryland has already joined. Dentists or hygienists must hold an active and unencumbered license to be able to practice and receive a compact privilege. Licensees must also pass a background check and meet additional criteria related to education examinations. As has been mentioned, from a regulatory perspective, the compact really doesn't change anything in Maryland. It preserves the authority of each member state to protect public health and safety through the existing regulatory structure. So the Maryland board would have jurisdiction over anybody practicing in Maryland, whether under a Maryland license or a compact privilege. Maryland will also be able to charge a fee for the compact privilege, so revenue impact to the board should be very minimal. Like all other licensure compacts, the Dentist and Dental Hygienist Compact will be governed by a commission that's made up of the member states, and the delegate will be a representative of the Maryland State Dental Board. As our sponsor mentioned, the compact is law in 10 states, including Virginia, with an additional 15 states that have pending legislation in 2025. Thank you for the opportunity to present this information, and happy to answer questions.
Thank you. I'm going to make one call for Christopher Arnold. We didn't see him in the virtual queue, so I don't think he's there.
Madam Chair, I think I heard that he was expected to testify in another bill hearing, and so was going to try. He may have had to drop off.
Okay, so we're going to start with Senator Kramer.
Thank you, Madam Chair. My question is for Matt with the American Dental Association. Matt, would you share with the committee, please, when it was that the ADA House of Delegates voted to endorse this compact?
The ADA House of Delegates has never taken a formal vote on the DDH compact. That's not the way the ADA governance structure works. The ADA Comprehensive Policy on Licensure contains a variety of positions on license portability, but one of the things that it does encourage state boards of dentistry to do is consider ways to make licensure more portable, and compacts are one of those items within that policy.
So the House of Delegates never took a vote on this?
That's correct. And the House of Delegates doesn't vote on specific pieces of legislation. That's why we have a Board of Trustees and a Council on Government Affairs.
Got it. Okay. Thank you, Madam Chair. Yes, ma'am.
So, Matt, I have a question. I guess Matt, ADA, whichever Matt can answer this. I was told in a meeting that the clinical training for this compact is very different than for the competing compact that we hear next, that you don't really have clinical testing and by exam for this compact. Is that accurate, please?
No, Senator, it isn't. So what this compact does is it actually preserves the idea that every state board is sovereign and gets to determine what is acceptable for clinical licensure in their state. And so what that means is a state like Maryland does not change their requirement that someone have passed a hand skills exam. And there's no question that that is the most common form of getting your license. However, there are other accepted or in some cases even required pathways to get your license. For instance, in 8 states, completion of a PGY1 or a postgraduate residency is allowed to be sufficient to get your license. And in New York, that residency is actually a requirement. And in order to do that, that residency program, of course, would have to be accredited. There also is an additional type of exam that is the newest in dentistry. It's called the DL-OSCE, and it is a computerized exam that is the rough equivalent of the NCLEX in nursing, but for dentistry. So what it would not do is it would not require Maryland to change its initial licensure requirements. What it would say is that Maryland would have to treat as valid a license from another state that is part of the compact.
So, Matt, that's my concern. When you talk about the computerized exam, does that include the actual clinical testing of the work that a dentist would do?
So, Senator, dental students start in clinic in their second year of dental school. The first year is pretty much all academic, and then starting in D2, they're in the clinic, and by D4, that's all they're doing. Dental students, before they can graduate from a CODA accredited program, undergo hundreds upon hundreds of these, what we would call hand skills exams. And so our point is simply that while the clinical hand skills test, the single encounter 1-day exam is one way to do it, that's not the only valid and recognized pathway to licensure. And there's no data to suggest that dentists who do or don't pass an exam, like for instance, the ADEX, are better or worse as dentists. There's simply no validity to that claim.
Thank you for answering my question. Senator Lamb?
Thank you. Just to follow up on the chair's question on this, I'm reading some of the testimony in the packet here, and it states that there's this concern, I guess, from our board of dental examiners that, to the chair's point, other states may have different requirements for the exams that they have to take. Some of these other exams may not require a hands-on component to it. And so if that's the case, just kind of reading out of this, candidates who cannot pass the required clinical exam would be incentivized to seek a compact privilege in a compact member state that does not require a clinical hands-on exam. So, by having this compact, you can have a candidate who, cannot pass the clinical exam here, go to a different state where their exam doesn't require a hands-on component, or there's no requirement for a hands-on component, and they could get licensed there and then have essentially reciprocity through this compact to here.
Sure. So, Senator, there is no state in which it is "quote unquote" easier to get a license than another. That simply isn't the case. Licensure standards in the United States for dentistry are about as uniform as you're ever going to get. Everybody needs to meet the same requirements, which is why we put those in the compact. You have to graduate from an accredited program, pass the integrated national board, and then take some form of a clinical assessment. The hand skills exam is not the end all be all. It is not the industry standard. It is not the necessarily agreed upon way that this is the only way to do it. It is one way to do it. It's the way we've always done it. But the idea that somehow the hand skills exam as it's developed is infallible or the only way to do it is really just not the case.
But you just said that it is the way that it has always been done up to this point.
Yes.
So on top of this compact and reciprocity, we're now also overlaying another change in that, like, this is the way it's always been done. This is a change in how somebody may or may not be required to have met a clinical component or the hands-on component of this, right?
No, Senator, that's not true. Other states have always adopted other options of being able to do this, for instance, a residency or the use of the OSCE. So again, the vast majority of dental students in America are going to continue taking some form of clinical hand skills exam. This is not a way around that at all. This is simply saying that a license issued in another state that is part of the compact is valid. This doesn't put Maryland patients at risk. I think ultimately the question that we have to ask ourselves here is, these state boards of dentistry, when they do this, they go through an exhaustive process of deciding whether or not to accept a particular exam or process for licensure. And so, we would have to go back and look and see, okay, is there any state that, in which something like malpractice claims are higher, or, there are more concerns about patient injury. And again, there's no data, no suggestion, none of that to back any of that up. The idea that the hand skills exam is the end all be all is just simply not the case.
I mean, I'm not saying that the hand skills exam is the end all be all, but it seems like it's an important component for a dentist to have proper hand skills, like clinical acumen. And so, I think the concern here is that different states can have different standards, different ways of meeting their state requirements. And by engaging in this compact, it really it gives up the ability of our state board to be able to have oversight and kind of jurisdiction over the types of individuals that could be licensed here in the state, because essentially we are an applicant, a person seeking licensure can go to the lowest common denominator state, which may or may not require certain components, get licensed there, and through this compact come back here.
Senator, there is no lowest common denominator. Again,
that's what every state says.
Well, but it's true. I mean, if you're working from the assumption that there is only one way to do this, then fine. But there is no such thing. And I would challenge the proponents of the other compact to present any sort of evidence that this exists. I mean, dental boards across the country all abide by a base set of standards to license people. Nobody wants to put patients in danger or license folks that don't belong that way. And again, I go back to the fact that every single dentist who would have to do this, like any dentist in America, has graduated from an accredited program where the standards must be met, including, I would again emphasize, hundreds upon hundreds of individual hand skills exams and working on patients, doing nothing but that by the time they graduate in their D4 year. Another pathway, again, as I mentioned, is residency. Somebody can graduate from a dental program, go straight into a PGY1, and work for another year, not only treating patients, but improving their clinical hand skills. That is the way it works in a lot of areas of medicine. And the DL OSCE is, again, as I said, the rough dental equivalent of the NCLEX, which is how every nurse in America gets their license. And so, again, we're not circumventing any standards here.
I would just venture to say that if there are certainly nuanced differences in the requirements for licensure and standards across the 50 states. If there weren't, we wouldn't have 50 different boards of dentistry or dental examiners looking at this with different requirements. We'd have one.
Thank you, Senator. Isn't that so? Yeah, I was waiting for that question. Senator Mounts.
Thank you, Madam Chair. Just a quick question for, I believe, Matt, because you've been answering all the questions so well earlier. Did I say that correctly, Madam Chair? Yeah. So in the bill, it's a big bill. Where is the commission authorized? Do they have any authority to deny a license or an application? So if you're an applicant and you're licensed and say, okay, the compact's in place now, I'm going to practice dentistry in Maryland, what discretion does the commission have? And where is that in the bill?
Sure. I'd like to defer to Matt Schaefer from CSG on that question. He's more familiar with the mechanics of this.
Sure, and thank you, Senator, for your question. So the commission has no power to grant or deny a privilege. That power solely lies with the member states of the compact to determine eligibility. So essentially, Maryland would examine their licensee population and see who meets all the requirements in the compact, communicate those up to the other member states via a shared data system. And that's how the Maryland licensees would gain access to the compact. So the commission, in terms of the governing body, has no power to grant or deny a privilege. That lies solely with the member states themselves.
Okay, let me try the question another way. So if perhaps there's a dentist or hygienist that's a problem, what would Maryland be able to do? What would the board, I mean, you're just being questioned about the board's testimony in opposition to this bill. What authority does the board have to or stop that individual from practicing?
Sure. If there's somebody that has a compact privilege in Maryland and they violate any of Maryland's laws and rules that govern the practice of dentistry, then they would be subject to the Maryland Dental Board, and they have jurisdiction to take an action on their privilege, just as if that person held a license. So they have full jurisdiction, fine, suspend, revoke, whatever they deem fit against a licensee for a particular action. And as Senator Guile mentioned in her testimony, that action would then be applicable across all the compact privileges that individual holds. And so there's really no scenario where a bad actor could hop from state to state undetected. There's some safeguards there.
Yep. And can you help me, where would that be in the bill?
So that's all housed within Section 6, which is titled Adverse Action, and that outlines the specific way that discipline occurs under the compact. And then again, as well, in Section 9, which talks about the data system, that talks about the reporting of disciplinary information that occurs under the compact.
All right. Thank you.
Thank you, Senator. I don't see any other questions for this panel. Thank you all.
Thank you, Madam Chair.
So I have about a dozen unfavorables. I'm going to start calling them up. Let's see who stayed around today. Dr. Beckett, Deborah Carty, Betty Howard, Dan Doherty, Chio Ali, One, two, three, four, five. Steve Wise. Y'all are braving the storm to be here. Thank you. Dr. Beckett, you want to start?
Good afternoon, Madam Chair, Madam Vice Chair, he's left me, and members of the Senate Finance Committee. I'm Dr. Thomas Beckett. I'm Legislative Chair of the MSDA, Maryland State Dental Association, and a past president of the MSDA. And I also happen to be a delegate from the state of Maryland to the American Dental Association. And I'm going to tell you, the past two House of Delegates for the American Dental Association, this compact came up for a vote. And both times it was referred back to staff. The key word here is the American Dental Association does not endorse a compact at this stage. It's all by staff. I want to put that out there right from the get-go. The other thing that I want to correct that I heard, and I looked it up on the infamous Google machine, May 2024 from Marquette. Marquette University School of Dentistry celebrated its first recipients of the diploma privilege to practice in the state of Wisconsin without ever taking an examination. With that background, I'm here in opposition to Senate Bill 21. You have my written testimony. I just want to highlight a few things. Other than that, I want to gear on the fact that in the state of Maine, the fiscal note for their compact bill was $250,000 a year for the first 3 years. The state of Colorado had a fiscal impact of $900,000 for their fiscal impact, and they're going to charge all licensees there for the compact privilege, whether they are compact privileged people or not. And there's a huge distinction in my mind, a compact privilege to practice versus a license. I hate to say it, I like the word license. A privilege denotes something different. Thank you for your consideration. I ask for unfavorable report.
Dan, you want to go next?
All right. Thank you, Madam Chair, members of the committee. I'm Dan Daugherty here on behalf of the Maryland State Dental Association in opposed to Senate Bill 21. And I'm going to address a couple of points that came up that I think need some clarification. While it is true that a remote state, not the primary state of licensure, can attempt discipline of someone who has a privilege, it is not an easy process. They have to comply with due process, which means, number one, they have to serve a subpoena. Even though the bill says that the compact dentist must agree to accept service, we all know that when people get in trouble, they don't always comply with what they agreed to, and they dodge it. Due process is a very complicated procedure. You have to have adverse hearings. They have to have representation. All of that's going on while this individual may still be practicing because they're under a privilege. If they were licensed, the board would have the ability to suspend their license promptly and then proceed and thus protect the public. That is not covered under 21 for remote licensees. I also would point out that evidence of clinical competency is not the same as demonstrating clinical competency. That is the big distinction. You can have someone that may show competency in filling a tooth, but they're totally incompetent in doing an endodontic procedure. The other, complete clinical testing, covers a broad breadth, and that's very important. Finally, I would say that dentistry is the one medical profession that is 90+% surgery. That's why it is different from all of these other disciplines that have compacts. And I thank you for your time.
Thank you.
Esteemed Chair Beidel and members of the Senate Finance Committee, thank you for the opportunity to speak in opposition of House Bill 45. My name is Deborah Carty, and I'm a registered dental hygienist. I'm also a member of the Maryland State Board of Dental Examiners. I'm also a grandmother, and my grandson John just recently received his driving license. He took a course, he practiced, and at the end, John's skills were assessed by his instructor. But simply completing the course did not deem John qualified. Passing an assessment wasn't enough. Only after passing an independent, hands-on examination administered by the MBA was Maryland able to issue John a driving license that was an example of how Maryland helps to ensure that a license is granted to someone who is ready. This process helps protect the citizens of Maryland. The profession of dental hygiene requires fine, hands-on skills to guide a bladed instrument below the gum line without harming the patient. The board currently requires passing an independent ADEX examination for both dentists and dental hygienists before granting a license to practice. When the ADEX exam is graded, 3 different examiners independently score a candidate. At least 2 examiners must agree that an error exists. It evaluates not only tartar or calculus removal for dental hygiene, but also soft tissue trauma and damage to hard tissues. The DDH compact simply requires, quote, passing a clinical assessment, end of quote. An assessment cannot be completed by a teacher. It is not equivalent to an independent examination. And for these reasons, the board opposes the DDH compact. Without rigorous testing, the board cannot guarantee that practitioners have the necessary skills and can competently treat Maryland citizens, which is a fundamental concern for public health and safety.
Thank you. Mr. Wise?
Thank you, Madam Chair, members of the committee. My name's Steve Wise. I'm here today on behalf of the American Association of Dental Boards. So that is the licensure bodies in all of the 50 states. I'm going to make 3 points that have not been made yet. This compact is modeled after others that has been indicated rely on a privilege. The next bill you're going to hear is modeled after the Interstate Medical Licensure Compact, which requires a license in every state. Why do I bring that up? This legislature entered that compact in 2019, and after a 3-year sunset, re-entered it and stayed in it in 2022. The practice of dentistry, has just been discussed, is very surgery-oriented. And yes, you have some compact privilege examples where you've entered into as a state of Maryland, but if there is another medical profession, another health occupation, where you want to make sure that the person practicing it is licensed by your board that you have control over, it's in the practice of dentistry. There's a lot of parallels between that and the practice of medicine. The second point, it was stated that 10 states have already entered the compact contained in Senate Bill 21, and of course that is 100% accurate. But don't misinterpret that to mean that all of those states had both compacts before it and chose the other one over this one. In fact, this compact was developed over the last interim, so Maryland is among the first group of states that has had these 2 compacts to choose from side by side, and it's pending in, I think, 5 to 7 other states right now. Finally, the committee hears a lot about access, and I understand that. That pervades all health issues. But we urge you not to put quantity of providers above the quality of providers. And by ensuring that they have a Maryland license and comply with the things that you require them to comply with, you're maintaining that quality. Under this compact, you risk losing control of that. Thank you.
Who's next?
I am.
Will you
Senator
pull the
Weil.
microphone? Thank you.
My name is Betty Howard. Good afternoon to everyone, Madam Chair and distinguished members of the Senate Finance Committee. I am a licensed dental hygienist practicing for 42 years in Montgomery County. I have served on Maryland's Dental Board and was honored to be the first hygienist to be president of the Dental Board. My experience as a dental hygiene examiner for 30 years has given me quite an insight. I often witness why the ADEX exam should be used to validate competency. I oppose Senate Bill 21. It represents a public safety risk with vague, diluted language regarding non-Council on Dental Accreditation educational programs, and it lacks the clear definition of a clinical assessment. Will that definition include a hand skills examination needed to validate competency? DDH compact threatens public safety by not requiring that validated hand skills examination, by diluting educational standards. There's an additional clause in the DDH compact that says the United States Department of Education can accredit educational programs. What will their curriculum be? Perhaps even a mentored preceptorship program, which is already happening in Alabama. Removing these safeguards allows untested dentists and dental hygienists to practice, risking patient care. Raising a major concern by lessening current standards that have existed in dentistry for decades. We would be at risk of developing a dual level of practitioner if the Senate Bill 21 becomes law in Maryland. So I ask you, please, to take a stand and preserve Maryland's current standards for the profession of dentistry and make an unfavorable report and oppose Senate Bill 21. Thank you.
Thank you. And our final witness?
Here comes closer.
Okay. Madam Chair, distinguished members of the Finance Committee, thank you for giving me the opportunity to testify today. My name is Dr. Chio Ali. I'm a general dentist. I practice in Frederick, Maryland, but I live in Potomac, and which is in Montgomery County, and I am the president of the Maryland State Board of Dental Examiners. I have a lot to say about this bill. I would like to respectfully request an unfavorable report on SB 21. This bill allows possibly unqualified, definitely unlicensed applicants to practice dentistry on our citizens in Maryland. Our mission as a board is to protect the citizens of Maryland. We are proud to have high educational and clinical standards, and this bill makes those requirements that were mentioned earlier optional. If you look on page 8, every single one of those things has an "or" attached to it. It could be a CODA accredited institution or another institution. The National Written Board exams or another exam. And the ADEX exam is not clearly mentioned. It is true. It says a clinical exam, but it leaves it so open to what kind of exam that is referring to. With all of these being optional in this bill, for an individual to be granted a privilege to practice on our citizens here in Maryland, we cannot ensure that we'll have highly qualified dental and hygiene applicants coming to our state. And it would be truly unfortunate and unfair to our citizens to have unqualified or possibly unqualified. We just don't know if they're not competently tested. So removing these competencies does not serve or protect our citizens. I wanted to also address the Service Members Civil Release Act. We have a procedure in place for that, and we have 13 service members and spouses who are currently under license with that and are happy, and it was a very seamless process to give them that. Lastly, the fiscal impact, of course, has been mentioned. There will be a fiscal impact to the state, the board, and licensees. And so we would really like to respectfully request to please give an unfavorable report for SB 21. Thank you. Thank you so much.
Dr. Ali, you mentioned that we have a process for our military spouses or military retirees. How long does it take them to get their license now when they come to Maryland?
It takes about 5 to 10 days maximum.
Really?
Yes.
And then they're licensed in Maryland?
Yes.
Thank you very much.
Thank you.
Imagine the sponsor would have questions.
I just have one quick question. So for the service members, Dr. Ali, for the Service Member Civil Relief Act, what kind of information do they need to provide?
They are providing their license information.
But what else? Do they have to provide orders to the state?
Orders? I'm sorry. What do you mean?
So let's say a military spouse, for example, if they want to get licensed under the Service Member Civil Relief Act amendments, what do they have to provide to the board?
They will provide the same accreditation from their school, the written exam and the ADEX exam.
Is there any other information? Do they need to provide proof that they're here on orders?
Yes, they do.
Okay.
Yes.
So what if their spouse has orders to the state of Virginia, for example, that they live in the state of Maryland? Would they be able to get licensed here?
If they have orders in Virginia?
Yes.
That is a good question. I would have to look to tell you exactly how that works.
I mean, I can tell you that the Service Member Civil Relief Act amendment requires orders to the particular state. So I'm saying we have lots of, for example, my husband served for 24 years active duty. His orders were always at Fort Belvoir. We always lived in Maryland. So consequently, I wouldn't be able to get licensure here in the state. Assuming, let's say, if I was trying to under the Service Member Civil Relief Act amendments, I wouldn't be able to. Is that correct, under that hypothetical?
I don't want to give you an incorrect answer, so I cannot answer that. But I can tell you that we have had several applicants, and we have not
Sure.
had any complaint. It's been very seamless.
I have no doubt, and I appreciate that, but I'm just saying that I think that that's part of the reason why the Department of Defense prefers compacts, is that there's lots of inherent problems, and that's just one example.
Sure.
But to that end, I appreciate it. I appreciate your testimony.
Sure. We are not in opposition to the compact. The opposition that we have is that we are lowering the standards, the quality of care. We don't want to put our patients at risk.
I appreciate that, and I know you testified to that. What I'm addressing really is with the testimony you provided regarding the Service Member Civil Relief Act amendment. So thank you. Thank you, Madam Chair.
Thank you. Mr. Wise, can you find out for us the answer to Senator Gao's question exactly?
Yes.
And get back to us on that. Thank you. Other questions for this panel? Seeing none, we're going to take the next 6 unfavorables. Thank you all very much for your testimony. Alex Van Diber, Sherry Cohn, Arthur G., Joy Voigt Holmes, William Castelli, and Andrea Jackson.
Madam Chair, Dr. Jackson is not able to attend.
Thank you. So, Mr. Wise, since you seem to know all the answers, is it snowing out yet?
It is.
Thank you. Mr. Castelli, would you like to start, please?
Sure. Thank you, Madam Chair. Members of the committee, Bill Castelli on behalf of the Maryland Academy of Pediatric Dentists. And we are also requesting an unfavorable report. I'm not going to belabor the points that have been made by the previous panel. They share a lot of the same concerns. Maryland pediatric dentists work with a lot of difficult patients, not because they are personally difficult, but infants, small children, adolescents, sometimes with disabilities, and that can be difficult. So we believe that keeping the current standards, Maryland having control of those standards is very important, and for that reason, we request an unfavorable report.
Thank you. Alex?
Good afternoon, and thank you, Madam Chair. And it's a pleasure to address the Senate committee today, Finance Committee. My name is Alex Vandiver, and I represent the Commission on Dental Competency Assessments as its executive director. Our nonprofit organization was founded here in this area in 1969, and our mission is to protect the public and serve state dental licensing boards by identifying and ready practice dentists and dental hygienists, and those that are not ready to practice yet. Currently, we are located in Linthicum, Maryland, have about 46 employees that work in the state and beyond. I'm here to testify against this Senate bill. Specifically, I'm not going to belabor other points, and I'll have other testimony later, but when the conversation came up earlier about the inability of the sovereign state being able to allow the states to be able to choose their exams, what that really does is that and disables Maryland from their choice, because Maryland was a charter member of the organization that founded the ADEX examination over 55 years, has this high standard of hands-on skills exams. And what this would do is this would force them to take another standard from other states. So really it takes the ability of Marylanders to make that decision and create that and what that standard is. Thank you.
Thank you. Are you Mr. G? No. Last speaker.
Yes. Madam Chair, members of the committee, thank you for this opportunity. My name is Arthur G., and I am the president of the American Association of Dental Boards, AADB. I'm also a 30-year dental practitioner in the state of Maryland, certified in oral maxillofacial surgery. I'm also the past chair of CODA, which is a Commission on Dental Accreditation. I'm currently standing on the Council of Dental Education and Licensure. At AADB, we are opposed to Senate Bill 21. Let me address a couple of quick issues that I've heard. Number one, Our main concern is that we developed an AADB counter proposal, if you will, a bill, because we oppose the concept of in the case of the concept of just a privilege only. When you look at this particular bill, it talks about privilege. Unlike other healthcare bills, they talk about a license privilege or privilege license, like in nursing. This bill only talks about privilege, and when you heard the original speakers talk about it is privilege, there's no mention of license. And I can tell you from all of the other states that have already adopted, there is considerable concern and struggle in interpreting the term of privilege. In fact, there's a lawsuit in Virginia regarding the item about how to interpret privilege. So I can state that the interpretation from Dental Board attorneys is that privilege is not a license. And with the state of Maryland, where it states statutorily that the Dental Board has only a jurisdiction over a licensee, this does not apply to privilege. And so it's hard for dental boards to interpret the, if you will, the answer that the ADA is giving is that licensees or privileged persons are under the auspices of the dental boards. So I want to make that clear. Thank you very much.
Thank you. Do I have questions for this panel? Thank you very much for your testimony. We do have a couple virtuals. We have one unfavorable and one more favorable. So Dr. Doring is back with us, virtually unfavorable. Thank you.
Thank you, Madam Chair and members of the Senate Finance Committee. Charles Doring, general dentist, Rockville, Maryland, and a happy Medicaid provider. One thing, and then I'll be a me too, that has not been discussed is I've just renewed my ePrep application. On that process, rather lengthy, it does require a copy of my state license. I don't think a privilege would apply. So having like portability, like the concept of it, but unless there's a license, they're not going to really be able to help in the access to care issue. The other thing I wanted to bring up is the fiscal note. I pulled that up on this bill and kind of scratching my head because there will be some kind of fiscal impact either to the state board, and that's going to be trickled down to the licensed dentists and dental hygienists and dental radiation, anyone who gets a license or certificate from the State Board of Dental Examiners, whether they're in the compact or not. With that being said, I ask for an unfavorable report on Senate Bill 21. Thank you for your time.
Thank you, Dr. Doring. Any questions for Dr. Doring? Thank you again for being with us. Thank you for not bringing us your cold. We appreciate it.
Thank you.
And then finally, we have Christopher Arnold, who was called earlier on the first panel, is with us as a favorable.
My apologies, Madam Chair, for my tardiness. Was testifying here in the great state of New York on the Nurse Licensure Compact, but the Department of Defense is grateful for the opportunity to support the policy changes proposed in the Dental and Dental Hygienist Compact. It's one of the 10 that we have developed thus far through our cooperative agreement with the Council of State Governments, which the Congress required us to enter into in 2019. There are 2 more under development, and in 2024, the Congress actually made that authorization permanent. So my name is Christopher Arnold. I'm the Mid-Atlantic Region Liaison at the United States Department of Defense State Liaison Office. As we know, military spouse licensure is a national security imperative, with our spouses still facing unemployment rates of up to 21%. The best evidence that we have about the quality benefits of licensure relate to occupations that tend to have more harmonized standards across states. Where we do not have any strong evidence is to suggest that the type of license recognition in the compact before you today is associated with worse quality or worse care outcomes. And this type of well-designed licensure regime enhances public safety while expanding healthcare access in historically underserved communities and improving family agility, workforce participation by historically underrepresented groups such as our military spouses. But the compact is significant in that, along with our active duty spouses receiving the benefit, members of the reserve component, the Guard members, their spouses, transitioning service members, veterans, and all practitioner of the occupation benefit from the mobility provided through compacts. So with that, I am pleased to be here. I'll be in Annapolis tomorrow to testify on a few, flying out of Albany Airport tonight. Hopefully they don't get snowed out, and I'll see you there.
Mr. Arnold, before you leave, I have a question for you. So it is snowing here, so you might get snowed out, but we just heard testimony from one of our dental board representatives that it's only taken 5 to 10 days for a dentist to get licensed in Maryland. Has that been the experience of your members?
Well, ma'am, I believe if I heard the question correctly, the testimony against was about state-specific licensing provisions that or accommodations that Maryland makes, and the Department of Defense pursues a variety of approaches to reciprocity simultaneously. So we view portability as a continuum. Our immediate ask is for states to issue their licenses within 30 days. In the near term, we want to see those licensing practices made accessible. Where I am in New York, we have a totally different regulatory model. The boards are advisory, and there's a central agency that handles all licensing. Our optimum end state are interstate licensing compacts, because if you're going from a compact state to a compact state, there's nothing you need to do. Your license is good to go. So there's no accommodation that the Maryland Board of Dentistry can make that's going to help a Maryland resident who is stationed in Virginia, or a Maryland military spouse who is serving in Colorado. It's great that you have those accommodations, but nothing short of the compact is going to help those individuals, which is why it is part of the basing scorecard and a critical component of our national security.
Before you leave me, one of the things we heard today is when you come to Maryland under the compact, you are not licensed. You are operating under privilege, so it's not a license. Did you hear that testimony? I lost you. I don't know what happened to the sound. We lost your sound, and you're not muted, but we lost your sound. There we try again. No? No? We'll check in later, Mr. Arnold. I don't know what happened, but thank you. Thank you for your testimony today. I appreciate you. That ends the hearing on Senator Giles' Senate Bill 21. We are now going to go to Senator Kramer, Senate Bill 538. Senator Kramer, can I bring up your first panel?
Please do, Madam Chair. I suspect it's going to sound very familiar.
I'm sure it will. Steve Wise, Arthur G., Alex Van Diver, and Dr. Andrea Jackson. I think Dr. Jackson is not here, if I remember correct.
Correct.
Okay, we'll start with that. Thank you.
Everybody up? Yeah.
Senator, I could call it more. Panel 2.
Yeah, it's fine. We're ready to get started, Madam Chair.
Go.
Good afternoon, colleagues. Ben Kramer introducing an outstanding bipartisan bill, Senate Bill 538, on behalf, pardon me, Madam Chair, on behalf of Senator Hershey and myself. And colleagues, I will share with you that the good senator from Anne Arundel County approached me and suggested we might settle this mano e womano. And in light of the fact that I bruise easily and I'm a bleeder, I chose to just leave it up to this committee with regard to the direction we take with regard to the dental compact. Colleagues, the adoption of the Interstate Dental and Dental Hygiene Licensure Compact by the state of Maryland is a crucial step toward enhancing access to oral health care, improving workforce mobility, and addressing provider shortages. This compact streamlines the licensure process, emphasis on licensure, allowing qualified dentists and dental hygienists to practice across participating states without the burdens of redundant licensing requirements. Maryland, a state with a diverse population and varying healthcare needs, joining this agreement means we would facilitate the recruitment and retention of dental professionals, particularly in underserved communities. Additionally, it strengthens Maryland's ability to respond to public health emergencies, supports military families facing frequent relocations, and aligns with broader efforts to modernize healthcare regulation. By adopting the compact, Maryland can position itself as a leader in advancing efficient, patient-centered dental care while fostering economic growth in the healthcare sector. Colleagues, I will turn it over to the panels to further discuss the distinctions between the two compacts. And I think you've already had the opportunity to get a sense of the concerns that were expressed earlier. And now you'll have a better understanding of why it is important that Maryland choose the right direction with regard to this matter. So with that, thank you, Madam Chair.
Thank you, Senator. I know you could go on a lot longer, so I appreciate your brevity.
It's getting late.
Mr. Wise.
Thank you, Madam Chair, members of the committee. Steve Wise here on behalf of the American Association of Dental Boards, which is the association of licensure bodies for the practice of dentistry across the country. I have a sense that the committee has gotten a pretty good picture of the difference between the two bills here, so I'm not going to revisit all the fundamental differences, but I'm going to use some of my time to respond to a question Senator Moutz asked, which is when you have someone apply through a compact, what is the role of the remote state, if you will? And I'm going to point you to the language in the two bills that governs that. And it's basically this. In the bill you just heard previously, a licensee of a participating state, so that's their home state, if you will, shall be issued a compact privilege in a remote state in accordance with the terms of the compact. So the remote state doesn't have the role there that it does under this compact. And under our compact, all of the laws and regulations of that remote state are observed. And this is on page 14. I am looking at the House bill, but I think it's the same. So let's take the example of the dentist who starts in Ohio but wants to come to Maryland. Maryland shall review the application to confirm compliance with the member state, Maryland's laws and regulations. Following such review, if they approve it, it issues the compact license. So every state that the person tries to go into gets that opportunity, and that's what makes it different from the prior compact and what makes it, I think, in our state's interest to adopt this compact, because you have that role and subjects them to the rules that you pass. So thank you very much.
Dr. G.
Madam Chair, my name is Arthur G. again, President of the American Association of Dental Boards. The American Association of Dental Boards is a member of all the dental boards in all the jurisdictions, the 53 jurisdictions. We have been ratified as an organization through Congress, the U.S. Congress, in 1889. So that's how long we've been in existence. As you can tell, we believe in compacts. We're not opposed to compacts, and that's why we propose this compact. This compact, the basic difference is the concept of license versus a privilege. And again, the issue is a privilege is not a license. But we've already said all of those issues, but let me address some of the other issues. This compact does exactly the same for military and military spouses that the other compact does. However, we go on one more better. Our compact extends 1 year to a military person once he has or she has left the military. So 1 year additionally, that person can belong to the compact at no charge and participate fully. So we believe that our compact satisfies the military requirement. And it is a compact, meaning again, that if you're in a compact, one state to the other state, the issue of license is an issue of jurisdiction. The issue is such that the compact preserves the ability of legislators to regulate the profession in the manner you see fit. The DDH compact, the other compact, is a compact that has a commission. It is ruled by the commission. The commission can make decisions on the type of exam that's given, the type of requirement that's given, and that goes through the commission itself. In the compact that AADB has, it is a licensure, and they are bounded by all the rules of the license of the state of Maryland. Thank you very much.
Thank you, Alex.
Thank you, Chairman Vital and the committee. I won't go through my background again for brevity, but I do want to mention just a couple of points that are important to complement the other parts of the testimony. We are the organization that that serves the examination portion of the compact before you. We are headquartered in Maryland, but we are a national organization. We serve the exam itself is accepted as the national exam standard in 51 different jurisdictions, 46 of which require hand skills examinations. And last year we tested over 13,000 dentists. That doesn't include dental hygienists, which is also a large number. What I'm trying to get to is that this is the standard in dental regulatory as part of licensure testing. We are at every single dental school in the U.S., as well as work in the Commonwealth of Jamaica and Mexico. There are important pieces that it's also important that Ms. Carty, I think, presented a little bit about how our examiners participate in the process. We engage over 1,000 different dentists and dental hygienists to act as examiner experts across the country. And as part of that process, the licensure candidates are offered, they are tested in multiple procedures in endodontics and prosthodontics and restorative dental care, as well as endoscopy. They have 3 different opportunities with each procedure to pass that examination. And as a consequence of that, over 98% actually meet the minimal competency standards, which also means that 1.5% to 2% of those individuals don't pass, are either not ready to pass or never pass the examination. And that's part of what we do to help protect the public, and is part of our mission. So thank you very much for the testimony, or for the opportunity to testify in front of you.
Thank you. So Alex, someone could go all through their years of dental school, all their clinical practice in dental school, and come to the ADEX exam and still not pass the clinical portion? Is that what you're?
That is correct.
Thank you for that. Any questions for this panel? Seeing no questions, thank you.
Thank you.
We're now going to bring up Dan Daughtry. Dr. Doring's going to be virtual. Dr. Beckett, Betty Howard. I see Dr. Doring's picture. It's very nice, but he's not there yet. Okay, Dan, you want to?
Thank you, Madam Chair, members of the committee. Again, Dan Daughtry here on behalf of the Maryland State Dental Association in support of Senate Bill 538. I want to make 3 quick points because we've gone back and forth over the issues. But first and foremost, both of these compacts and the other compacts that the state has considered provide that commission rules supersede state law. But there is a difference between 21 and 538. In 538, the Interstate Licensure Compact, its provisions and the rules promulgated shall have standing as statutory law, but shall not override existing state authority to regulate the practice of dentistry and dental hygiene. That's on section 12A on page 18 of the bill. The other compact under 21 says its rules and regulations shall supersede state law except as to scope of practice, which is a much more limited issue. Basically, it's saying whether a dental hygienist can extract a tooth, et cetera. But this 538 does not supersede state law in its regulation of those two professions totally. And that's very important. Secondly, the fiscal impact issue. There will be a fiscal impact under 21. It's been shown in the other states. The commission has had to start its whole establishment, its database, and that cost is to be passed on. While AADB commission can charge a fee, they've got all of that implementation in place, so it would be much, much less. Thank you.
Betty Howard.
Oh, thank you, Senator Beidel. We've talked a lot about the parts of these compacts, and what I'd like to speak to is my experience as a chief clinical dental hygiene examiner for the Council on Dental Competency Assessments and the Western Regional Board and the Commission on Interstate Testing Agency. So again, my name is Betty Howard. Thank you all for my time here today. But I experienced an examination in December as the chief. I don't grade any of the candidates that are there. I'm there to observe as a proctor for the exam. There were 7 candidates from the school. They performed beautifully. They all passed. Everything went well. There were 4 candidates that were not from the school. One was a formally trained hygienist at practicing for many years, left the practice, and was retesting to come back to practicing dental hygiene. She'd never worked on a typodont before. She was able to completely remove all the deposits, did not endanger, cut, depilate any area of that typodont. She did a beautiful job and was successful. The other 3 candidates, I watched each one of them struggle. I do not know what their training was, but they did not remove the deposits. Every one of them, the 3 of them, were unsuccessful, massive deposits left behind, and one of them had cuts in several areas of the model's gum tissue. So there are reasons why we have our clinical examination, the hand skills. We work in a very confined space, and our expertise is unprecedented, I think, in the world for dental hygienists. And I just want to say I hope that you will speak in favor of upholding Maryland's standards of licensure by voting in favor of Senate Bill 538. Thank you for your time.
Thank you, Ms. Howard. And Dr. Doring?
Madam Chair, members of the committee, first off, I'd like to thank Senator Kramer for sponsoring this bill. And with that, I say me too, and everyone get home safely, and ask for a favorable report on Senate Bill 538. Thank you.
Thank you, Dr. Doring. All right, we have another panel.
Madam Chair, can I just say one quick thing? I didn't say anything yet.
Oh, I'm sorry.
That's all right. That's fine. It's a long day. It's a long day because I'm going to make it really short. I'm Dr. Thomas Beckett, Maryland State Dental Association Legislative Chair and past president, and I'm going to say, me too. I ask for a favorable report on Senate Bill 538.
Senator Kramer.
Thank you, Madam Chair. Dr. Beckett, quick question for you. You indicated that you're a member of the ADA House of Delegates. Is that correct?
That is correct.
So maybe
for over 20 years. So
for how long?
Over 20 years.
Over 20 years. So could you just quickly, because the day's grown late, but in my question of the representative of the ADA a moment ago, I asked about the House of Delegates having voted in approval of the other compact, and it was simply shared with us that that's not a predicate for making decisions that it's evidently others who decide what the ADA will do. Could you quickly opine on that for me? I mean, what is the purpose of the House of Delegates if others can simply say, no, we're making the decisions?
We have a policy in place for license or portability. It's been around for many, many years. And that's the mantra that they were using to go through this compact. In 2023, the compact specifically was brought in front of the House of Delegates and was referred back because it was insufficient in our minds. It came back again in 2024, and the same result happened. The House of Delegates did not feel that the compact language was appropriate. It was referred back for further study. But we do have a policy on licensure mobility. I think it's probably been around since before I became a dentist.
Okay, but so the members of the broader association, I'm assuming that's reflected through the House of Delegates, is that correct?
That is correct.
Okay.
The state of Maryland, we have 7 delegates. There's 400 and something over the entire country.
Okay, and they have not endorsed this compact?
They have not.
Okay, thank you for that.
I can provide you with that information if you would like.
Terrific, thank you. I appreciate the clarification.
Thank you, Dr. Beckett. Again, I'm sorry. I just went down the row.
Not a problem.
Thank you. I think Dr. Ali, Joy Boyd Holmes, Deborah Carty.
Thank you very much, Madam Chairman and esteemed members of the panel of the committee, the Finance Committee. Again, I'm Dr. Chio Ali, President of the Maryland State Board of Dental Examiners. We are in support of this bill, Senate Bill 538. I believe that it alleviates the question about which state the military member or spouse is stationed in. What's nice about this is that we are going to be issuing a license, not a privilege to practice. The home state board will issue a letter stating that the applicant has passed the ADEX exam, has passed their national board exams, and they have graduated from a CODA accredited institution. That letter comes to us, our board, and because those have been met, we can issue a full license to that individual to practice, and that ensures that we have quality. We want access to care. We would like for Dr. Doring and others with Medicaid to be able to put their license number to practice in underserved populations. And so this bill addresses those concerns, and I think it provides access to care, quality care for our citizens. And the fees were discussed briefly as well. The fee is for the applicant of the compact licensure. It will not be levied. It will not be assessed to all applicants. It will be assessed to the applicant who wants to be part of this to be able to get the compact privilege and obtain a license in participating states. Thank you very much. Thank you so much.
And one more.
I think I'm the last one. Thank you.
No.
No, there's more. Okay. Thank you, esteemed Chair Vidal and members of the Finance Committee. As you know, I'm Deborah Carty. I'm a registered dental hygienist. I'm on the Board of Dental Examiners. I'm speaking on behalf of the board. A licensure-based compact like the IDDLC offers a clear, structured pathway for licensed dental hygienists to practice across state lines without compromising care quality. The key advantage of this model is that it contains consistent licensing standards for education and testing that parallels Maryland's current licensure recommendations, ensuring competency and accountability, especially recognizing the ADEX examination for verifying a candidate's psychomotor and didactic performance for practice. The board supports the IDDLC compact because it helps safeguard that all practitioners in Maryland will meet a uniform requirement proven to preserve public health. I respectfully urge the committee to carefully consider these issues and return a favorable report. And I would like to just add one more thing, Chair Bidel. You were asking, it seems ridiculous that someone could complete 2 years of education and not pass this examination. I had a particular school ask me to look at a candidate who had failed the exam twice. their pen grasp was like this, which is not uncommon in today's younger generation. To hold an instrument, it's called a modified pen grasp, where you hold your thumb and index finger across from each other. This particular student was not holding the instrument properly, and her finger rolled over the instrument. And when that happens, you cannot use your thumb to roll the instrument to go around line angles. And something as simple as that should have been caught early was not. So for that reason, yes, people do fail the exam.
Thank you for that. We have a question from the sponsor of Bill 21.
Yeah, thank you very much, Madam Chair. There's been a lot of discussion about costs, and I'm wondering if, I'm not sure who would be better to answer this question. What kind of resources would be needed in order to implement the model that's been proposed under Senate Bill 538?
Well, the infrastructure is already present with the AADB. What the cost would be is the board cost to issue the license, which is what the applicant would be paying for.
Okay.
Really.
We've heard testimony about that, some concern about whether or not the fiscal note on the previous on the previous Senate Bill 21 that may be incorrect, and I'm wondering if you may be able to give some information based on what other resources. It sounds like you're saying that there's no other resources that may be needed in order to do this based on that there's existing infrastructure.
Yes,
So there would be a commissioner that would be
okay.
But that would be someone who is already on the Board of Dental Examiners. So I don't know that.
Right.
I guess what I'm trying to understand is if there's a concern that's raised that there's going to be a huge fiscal impact by the other compact, what is it about this that is believed to make this like less resources?
Well, the other compact states clearly that it's going to assess fees for the operational costs, the activities, and to the state. So the state is going to be assessed, and where is that going to go to? That's a fact that's in the bill. It says it's going to assess the state. It's in the bill, and it will assess. And where is that? Where is that going? It's either coming out of the state, or it's going to the board, which means the board has to raise fees even further to cover that fee. And we've already seen a couple fiscal impacts from other states that show what is a possible fiscal impact that is going to be given for the state or to the board, and therefore pass on to the licensees.
Okay, and is it your belief that as an AADB has the resources in order to do this?
Yes, I believe so.
They made that. You believe
that
so?
will be a question for AADB.
Okay. All right. Thank you. Thank you, Madam Chair.
Thank you, Senator. I don't see any other questions. Have a couple more to testify. Thank you.
Thank you very much.
Sherry Cohn and Bill Costelli. And then we have one more virtual.
Dr. Cohn is not here, Madam Chair.
Okay. We have Mr. Costelli and one more virtual.
Thank you, Madam Chair. Bill Castelli on behalf of the Maryland Academy of Pediatric Dentists. You heard our testimony for the prior bill. We do support this legislation and we encourage a favorable report for the reasons we mentioned before. We do think this provides an expedited licensing process and does address many of the concerns that the other compact bill does, but still retains a lot of control for the state, and for that reason, we encourage a favorable report.
Thank you, Mr. Costelli. So we have two unfavorables. Matthew Schaefer, you want to go first?
Thank you, Madam Chair. Again, Matt Schaefer with the Council of State Governments. We believe Senate Bill 538 really fails a lot of the best practices that CSG has honed over decades of drafting interstate compacts. We prioritize openness, transparency, opportunity for public participation. Senate Bill 538, the language for it was developed over the course of a few months by a small number of state dental board representatives and the dental testing company that you heard from earlier. There was no public notice of the efforts or no opportunity for stakeholder input or review. I'd also like to emphasize that there's currently 5 other states with legislation, and in reviewing the language as introduced, CSG did find significant material deviations among these bills. As this committee knows, compacts operate off of mutuality of obligation. All of the states need to be agreeing to the same terms, and thus consistency and standardization of the language must be uniform. So by enacting Senate Bill 538, Maryland would be joining a compact where there are different versions of the language being considered in the states right now. I'd also like to just speak to this conversation around privilege versus license. So from CSG's perspective, we discussed this thoroughly during the development process with the stakeholder group that we put together, and it was determined the privilege model was the best way forward for dentistry. And I think the main thing I would emphasize here is cost. So just for reference, to apply to get a license in Maryland under the Interstate Medical Licensure Compact, the physician is paying a $700 fee to the commission and an additional $790 to the Maryland Dental Board, or Medical Board. So that's nearly $1,500 for a physician to use the compact to get a license in Maryland. So we believe this would be cost prohibitive for dentists and hygienists, and thus went with the privilege model. So thank you for your time.
And Matt Rossetto.
Thank you, Madam Chair and committee members. We appreciate the opportunity to testify on Senate Bill 538. The ADA is opposed to this proposal. I would like to draw the committee's attention to two particular issues that we have with this bill. The first is the requirement that any applicant under the AADB compact have taken the ADEX exam to the exclusion of all others or face a 5-year waiting period to use the compact. To be clear, a new dentist just out of school possessing a valid license earned by passage of a clinical assessment other than the ADEX would be unable to use the AADB compact for 5 years. A license to practice dentistry or dental hygiene is no more or less valid based on the type of exam that a practitioner has passed. It also clashes with the principle that each state board of dentistry is the ultimate arbiter of which exam pathways are valid in their respective states by suggesting that their standards are somehow lesser. The second concern has to do with discipline. The AADB compact enacts a permanent ban on the use of its compact on anyone who has ever, for any reason, had a mark of discipline against their license with the exception of a CE-related violation. This is, with respect, an arcane attitude toward discipline and justice. It is also out of step with the report issued in December by Governor Moore's Government Efficiency Commission, which specifically identified easing barriers to licensure as a priority. We believe that if a licensee has completed all of the conditions placed on their license and has had it restored to full and active status by a state board of dentistry, they should be able to use the compact. We believe and trust that boards of dentistry do their due diligence in determining when and how a provider should receive discipline, and we equally trust their judgment on when and how to lift any sanctions it may have placed. Therefore, we would urge the committee to vote no on this legislation and would welcome the opportunity to answer further questions. Thank you for your time.
Senator Guile.
Thank you very much, Madam Chair. I think the question is for CSG Matt as opposed to ADA Matt. We've been talking about like the fiscal impact of both of these compacts. I'm wondering if you could speak a little bit more towards to that point.
Yeah, so I talked about the cost to the physician to use the medical compact, but it's also the most expensive compact to administer. The IMLC operates off of a budget that's nearly 10 times more than any other licensure compact. I think it's over $5 million annually. And that's because of the administrative cost that the commission is engaged in to actually get you licensed in every state where you want to practice. So the commission is essentially a clearinghouse that does all the paperwork and application processing to get you licensed very quickly. And that comes with a lot of staff time, whereas under the privilege model, that's no longer necessary. And so it's significantly less costly to administer and also less costly to the licensee. So there's some streamlining there because you're not actually having to apply for and obtain and maintain separate individual state-issued licenses.
Thank you very much. And then ADA, Matt, if I can, just one question. Did to your knowledge, has a House of Delegates taken up this particular compact for any vote?
They have not.
Okay. And could you explain why they haven't taken up a vote on this? I know you talked a little bit before. Is there a reason why they haven't taken up a vote on this one or the other one?
Yeah, absolutely. So, and this is, I hate to spend time getting into the internal politics of the ADA, but this is, since the question's been asked, here we are. The reason that we're here and able to do this is because the ADA has a series of policies. That's how any organization operates. Those policies come up for a regularly scheduled review every 3 or 5 years. The compacts are contained within what's called the Comprehensive Policy on Licensure. And as the name suggests, it's comprehensive. The reason that the House of Delegates referred that policy back to committee twice, which Dr. Beckett was correct, they did do, is because the policy has been completely rewritten and restructured twice over the last couple of years. It had very little to do with the actual compact itself. We're talking an entire multi-page policy being referred back. To answer your question as to why the ADA House has never taken an up or down vote on the AADB compact or on this bill is because it's never been proposed.
Okay, thank you. And just to be clear, you're here under the authority of the ADA as a representative of the ADA that has endorsed the and in support of the Senate Bill 21 that we just presented prior to this one, correct?
I am. I had to get permission to do this. I can't just go off on my own.
Thank you very much, Matt. I appreciate it. Thank you, Madam Chair.
Thank you, Senator. I have a question for CSG, Matt. You talked about, thank you, you talked about the cost to a physician if he comes in under Senate Bill 538. What's the cost to a physician under Senate Bill 21?
So under the privilege model, the cost is significantly less because, again, the commission is doing no work to get you licensed. Your license granted by your home state is being recognized as valid. So just as an example, the PT Compact has a application fee of $45 to the commission. So the physical therapist would pay that $45, and then anything additional that the remote state wants to place on top of that. So the difference there, $700 to apply to the medical compact versus $45 to apply to the PT Compact.
Is that because you don't actually have a license? I mean, the fees that you're paying under Senate Bill 538, they're actually paying licensing fees, correct?
Well, and they're paying for the administrative work that it takes to produce all the documentation, all the paperwork to get you licensed in that remote state. So the staff for the medical compact is doing all the legwork to get you licensed in all the states where you want to practice, rather than you applying individually to each of those state boards. So it's saving you time, it's saving you the administrative legwork, but you're paying for that with that $700 fee.
Thank you. Thank you for that. Any other questions for this virtual panel? Thank you very much. That ends the hearing. This ends the hearing on Senate Bill 538 and ends the hearings for the Senate Finance